بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. وأسعد الله صباحكم بكل خير. Ladies and gentlemen, good morning everybody. And let me just, before we start our scientific session, I would like first to thank President of SASPGHAN, Dr. Muad Troiki, and organizing committee and scientific committee for their great effort to organize this very interesting, and I hope to be very enjoyable to everyone. This is the 7th International SASPGHAN Conference. Thank you for all the speakers, the international and the national speakers. And we're gonna have a couple of days of this scientific conference. And I'm Dr. Shawish, pediatric gastroenterology in King Fahd Armed Forces Hospital. I'm just retired, so pray for me. And my co-chairman, Professor Ahmed Sarki, he's a professor of pediatric gastroenterology in King Saud University in Riyadh. So we're gonna start the first session. The first speaker is Dr. Maher Al-Hatlani. Dr. Maher Al-Hatlani is a consultant pediatric gastroenterology and the head of pediatric in Al-Imam Abdul Rahman bin Faisal Hospital in Dammam, Ministry of National Guard Health Affairs in Kingdom. And Dr. Maher is going to talk about recent advances in treating celiac disease. So the floor is yours.
Thank you very much. ما في screen. Okay. Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Shawish and Dr. Ahmed. Bismillah ar-Rahman ar-Rahim. Today we'll talk about one of the common disease with high prevalence, almost 1% in Saudi Arabia. And we would like to talk about few advances in the treatment which currently have been published in the literature. So today my talk will be about the introductions about the celiac disease and some pathogenesis and possible mechanism, and 5 broad approaches, and ended by conclusion. So as we all know, currently there is no, the only available treatment for patients with celiac disease is a strict gluten-free diet. And a lifelong diet completely free of gluten can be very costly and challenging. Many patients' intestine don't heal completely and they continue to suffer from symptoms, most often due to the imperfect adherence to the gluten-free diet. And despite patients' best effort, accidental ingestion of gluten through cross-contamination continue to jeopardize their health as well-being. So if we go to the mechanism of the celiac disease, we can observe that we do have at luminal level, mucosal level, and submucosal level. So in the luminal level, we do have the gluten and the toxic gliadin, in addition to other toxic prolamines from other cereals like rye and barley. When they interact and transmitted through the membrane, through the tight junction, reach to the lamina propria and cause a pro-inflammatory and inflammatory reaction cascaded by activation of many innate and adaptive immune cells, ended by huge cytokines and antibodies released that ended by flattening of the villi and then crypt hyperplasia. So we do have few mechanisms that can be possible treatment for celiac disease. Either we go through the gluten, we detoxify gluten and gliadin, we sequester gluten and gliadin in the lumen, or digest that one before it reaches to the mucosal and submucosal area. We may use protein mimic the tight junction, and that one will prevent the transmembrane of the gluten. We may use blockers to the deamination through the TG2, and we may use some blocker to the HLA DQ2, DQ8 ABCs, and we may use anti-cytokines and interleukins like IL-15, and some of the lymphocyte homing mechanism like using of the CRX. So first one have been published is the latiglutenase, which is that to block the immunogenic mechanism of gliadin peptides. And we will go through the details of each one. Second one, as we mentioned, is the using of the protein that can fix the tight junction disassembly. And then we can use the TG2 inhibitors. That one can block the deamination of gliadin peptide when some of the amino acids have been changed in the gliadin, making it more immunogenic and trigger or picked up by all HLA-DQ28 cells in the ABCs that trigger a cascade of inflammatory reactions. Or if we fail for all these 4 steps, the final steps will be utilizations of the immunogenicity of the lumen and submucosal by either vaccinations or by using of anti-IL-15 anti-CD3, anti-CD20s, and other pro-inflammatory cytokines. So we do have classically 5 strict approaches. Either we decreasing the immunogenicity content of gluten, or we sequestering gluten in the gut lumen before it digested into immunogenic peptides and absorbed. We may prevent the uptake of digested gluten through intestinal epithelial tight junction, or we just block the tissue transglutaminase to prevent the enhancement of immunogenicity of digested gluten by the enzyme TTG enzyme. Or finally, we prevent the downstream immune activations after the uptake of the gluten when we reach at the level of anti-IL-15 and others. So initially, we do have the endopeptidases like ALF-V003, ALBEP, and STAN1, or we do have at the lumen level the gluten sequestering polymer or probiotics. As we know, the gliadin and the toxic part of the gluten and other prolamines in other cereals like rye and barley, they are not digested, although they are proteins, they are not digested by neither the gastric, duodenal, nor pancreatic enzymes. Second, at the level of the luminal level, below the luminal level is the tight junction mechanisms. When we use the larazotide, which is the tight junction modulator that mimic the zoline, or we do have the submucosal level when we are dealing with other agents like TG2 inhibitors or DQ2 blocking agents, or the gluten tolerance like the vaccine, or using of the CRX antagonist, which is used in IBD also, or using some of the anti-inflammatory like IL-15 or and others. Okay, we'll talk first about the endopeptidase ALF-03. It is the latiglutenase. It's a combination of ALF-1 and EBP2 cysteine endopeptidase that is driven from the endosperm of germinated barley, and also ALF-2, which is the Sphingomonas capsulata, also as endopeptidase. ALF-1 degrade the gluten protein and reduce their immunogenic potential of gluten. And in phase 2 clinical trial, it's shown that it attenuates the gluten-induced small intestine mucosal injury in patients with celiac disease. Another phase was not that much conclusive, and there is no much improvement in the histological findings. Conclusion, additional studies are needed to fully evaluate the therapeutic potentials of endopeptidase therapy in celiac patients. Second is the gluten sequestering polymer, namely BL7010. That one is a synthetic non-absorbable polymer of cysteine sulfate. This polymer is reported to have very high affinity to the alpha-gliadin peptide in the lumen. Proposed mechanism is just sequester intraluminal gliadin. A preclinical studies in the mouse was very good and showed some effectiveness and preventing the gluten-induced reduction in villus to crypt ratio, intraepithelial lymphocytosis, as well alteration in the paracellular permeability. Conclusion about this one, while the concept is very interesting in sequestering gluten before it reaches the small intestine, we need more data about the safety and the risk of finding other peptides inside the lumen, like medications. Probiotics. Probiotic work by down-regulating the pro-inflammatory immune response in celiac disease. Many studies have been published and about the effect of probiotics. One of them is the Bifidobacterium infantis, was associated with the improvement of the symptoms. Well, the baseline antibodies titer was not that conclusive in control group. and the intestine permeability measured by urinary lactose to mannitol fraction excretion ratio was not significant. Conclusion for probiotics: there are no firm guidelines to recommend probiotic use in all patients with celiac disease. Fifth one is the tight junction protein modulator, which is the one we recently have been published in the last 2 years about the larazotide acetate. Larazotide acetate is one of the future medication that may be used by end of this year, which is the synthetic octapeptide, whose sequence was derived from the Xenola occludin toxin from the Vibrio cholera. And it's improved the tight junction integrity, and it has a lot of potential apart from the celiac disease to be a treatment for other GI disorders in adult and pediatrics. A recently completed phase 2 clinical trial showed that larazotide 0.5 milligram 3 times a day can reduce the symptom while you are on gluten-free diet, on top of gluten-free diet. So it cannot be used alone. The study represents a successful trial of larazotide as a novel therapeutic agent in patients with celiac disease who are symptomatic despite he is on gluten-free diet. Conclusion: while these data are promising with regard to the symptom improvement, lack of information on historical improvement despite symptom improvement is a drawback in these studies. Then we have the very interesting one, which is the DQ2 HLA and DQ8 blockers. They are in susceptible individuals, as we know. The deamidated gliadin peptide will have high affinity to those cells, ABC cells with DQ2 and DQ8 satellite or marker or expressed in their surface, and that stimulate the cascade of inflammatory reaction, which is the gliadin specific T cells, ended by stimulation of the innate immunity and activation of both T helper and cytotoxic T cells. The activation of that T1 and 2 inflammatory pathway may have a self-rule in ensuring additional peptide through the lamina propria. That blocking of DQ2 and 8 lead to good presentations of the healing and decrease the inflammatory cells and preventing the cascades of the cytokine release. Conclusion about DQ2 and 8 blocking agent is a novel therapy, and it's remained until this moment in the preclinical phase. Then we have our friend, which is the TG2 inhibitors. As all we know, that tissue transglutaminases have presented in many parts in the body. 4 to 5 organs, they have TG2 with other names. It's a major role in the celiac disease pathogenesis, and it can cause amidations of the gluten when the glutamic amino acid have been replaced by other amino acid and make the gliadin more irritant to the immune-based response inside the mucosa. So if we inhibit the TG2, we may prevent presentation of that gliadin or the gluten peptides by the antigen-presenting cells, which has a receptor rich by HLA, DQ, and DQ8. So you cut the inflammatory reactions. So it's proven to protective against gliadin-induced toxic effect, an increase in CD20 and IL positive cells, and as well upregulating of the T regulatory cells, Krebs cell proliferation. All of them have been controlled with the TG2 inhibitors. The medication, which is known as Z1227, is a new drug which acts direct and specific inhibition to the TG2 in patients with celiac disease. Conclusion, the drug was already tested in phase 1 clinical trial and have been shown to be safe, and a proof of concept study will be enroll patients with celiac disease in phase 2 clinical trial. And this is the number of the clinical trial plus the references. Well, now is the hookworm and the story of hygiene theory in many GI disease. It is hypothesized that intestine parasite infection help regulate the immune system and prevent autoimmune and allergic disease. According to the hygiene hypothesis, lack of early childhood exposure to the parasite has been created as predisposition to develop autoimmune disease in developed countries. Several randomized double-blind placebo-controlled trial was conducted to study the effect of wormwood on the gluten or gluten challenge in patients with celiac disease. Well, the conclusion, it doesn't restore the tolerance to in moderate consumption of gluten, but really it was associated with improvement in the symptoms, and if the gluten was ingested in the low dosage. Celiac disease vaccine, as we know, the vaccine story have been withdrawn by end of June, July 2019. The one is called Nixavax, and which is a peptide-based. Well, it causes like the immune tolerizing agents. The study was not conclusive. In June, was discontinued because there was no protections from gluten exposure in compared to placebo. Cathepsin S inhibitors is one of the medication that has a role in antigen presentation of the gliadin to the MHC class 2 cells. And this medication is orally administered. Phase 1 randomized double-blind placebo control have been investigated, and the conclusion of this one is we are awaiting for the result of that phase 1. Immune cell targeted therapy. I'm okay with the time. Immune cell targeted therapy is IL-15, which is cytokine that regulate the activations and proliferation of the T lymphocytes, as well the NK cells. IL-15 lead to increase in the number of intraepithelial lymphocyte, which is a classic finding in patients with celiac disease. The medication called tofacitinib, which is a pan-JAK inhibitors that block IL-15 signaling, and it has been approved by FDA in treatment of rheumatoid arthritis. Celiac will have been in mouse module be effective on those overexpressed with IL-15. Conclusion for that, it's considered to be used in celiac disease, especially those with refractory, we can use the tofacitinib. The classic usage is usually for dermatitis herpetiformis patient with celiac disease. Anti-CD20, anti-CD3, that one, as you know, it will be just help both in T helper cells as well the cytokine T cells that release the antibodies and cause the cascade of series of inflammation and reaction to the lamina propria, which will be ended by permeability and flattening. So theoretically, the anti-CD3 antibody, which is called teplizumab, may be has a potential in the treatment of celiac disease, and a study have been identified that T regulatory cells can be induced in vitro by anti-CD3 antibodies. The published data are lacking to support the use of anti-CD3 in celiac disease. This is one of the latest very interesting antagonists, which called the CCR9. R9 is one of the antagonists that prevent the recruiting or responsible for the recruiting of plasma cell lymphocyte in the lamina propria. So it is a chemokine receptor known to be essential for lymphocyte migration in the intestine. It's the name, the generic name is fercerinone, and studied in IBD very widely, although it showed efficiency in inducing response in early study. It was not confirmed in in phase 3 clinical trials. Conclusion for CCR9, it is given that the homing mechanism of lymphocyte that will be blocked by this medication, we are worried about increasing the risk of infection, particularly the GI infection, especially we are dealing with children or young age group. By the end now, the gluten-free diet is the only available treatment for celiac disease and will be remaining the mainstay of treatment until safe adjunct and alternative are available. And there is an unmet need for potential non-dietary therapy for celiac disease, as we observe. And while many trials are ongoing or underway to explore non-dietary treatment of celiac disease, there is no consensus and outcome measure in the celiac disease trial. Larazotide, anti-TG2 inhibitors, and anti-HLA DQ2, DQ8 is the most potential future treatment for celiac patient. Thank you very much for your listening and for the chance to present this talk.
Thank you very much, Dr. Maher. I think we'll keep the questions for the end of the session. The next speaker is the Dr. Going to be ready or not yet? So the next speaker is Dr. Wael Bahbah. He is a pediatric professor of pediatrics and clinical nutrition at the College of Medicine at Al-Manoufiya University. Dr. Bahbah is the president of Egyptian Academy of Pediatrics, and he is going to speak to us about the iron story from traditional iron salt to chelator. Is it a revolution? He's going to speak to us virtually from Egypt, so we're waiting for the screen.
Dr. Wael, can you speak? Please, can you unmute yourself and start to speak, please? And turn on your camera.
Yes, please. Good morning, everybody. Good morning to all. I am Professor Wael Bahbah, Professor of Pediatric and Pediatric Clinical Nutrition, Manoufiya University, Egypt. Sorry for
okay, Dr. Wael, please, can you turn on your camera and share your screen?
Yes, please. I'd like to. I have a recorded lecture. Please, can you play the record? Okay. And we will be live after question and answer.
Okay, sure. Thank you so much.
Yes, hello everybody. I'm Dr. Wael Bahbah, Professor of Pediatric and Pediatric Clinical Nutrition, Manoufiya University, Egypt. It's immediately prestigious to be one of the scientific committee and speaker in such prestigious conference. Congratulations, Professor Ali Al-Mehidib and Professor Muad for this highly scientific and organized conference and prestigious conference, and thanks for your kind invitation. Our talk today is iron story from traditional iron salt to chelate. Is it a revolution? This is the agenda. We will speak about definition of iron, role of iron in the development for brain development, type of iron, source of iron, daily iron requirement, hemostasis, stage of iron deficiency anemia, definition of the iron and risk factor for iron deficiency and iron deficiency anemia. Also, we'll proceed to prevalence of iron deficiency and the impact of iron deficiency and iron deficiency anemia with screening for iron deficiency and the iron supplementation strategy for treatment. Now, iron is the most abundant element on the Earth, accounting for 35 of the Earth's masses, and it is essential trace element necessary for many metabolic reactions in the body. This present role of iron in the body formation of hemoglobin, carry of oxygen, brain development, energy metabolism in the body, regulation of body temperature, and also immune system. Iron and the brain development. Iron is essential for energy production, about energy or production and ATP utilization, high in the fetus and in neonate. Also as a neurotransmitter to make dopamine, serotonin, and norepinephrine. Also during myelination. Also, what type of iron? There is heme iron and non-heme iron. Only food derivative from animal flesh provide heme, but they also contain a non-heme iron. All the iron in the food derivative from plant is a non-iron. Heme account of about 10% of average daily iron intake, but it is well absorbed, about 25%, while non-heme iron account for the remaining 90%, but it is less well absorbed, about 17%. Sources of iron were in leafy vegetables, cereals, milk, egg, meat, spleen, and also liver. Daily iron requirement. Here we show the daily iron requirement for iron. We saw infant from birth up to 6 months need 0.27 milligram per day, while infant above 6 months from 7 to 1 year need 11 milligram per day for recommended daily allowance for iron. This is the iron hemolysis strategy, and all we know iron hemolysis with dietary iron absorption, ferric to ferric, and enter the cell, and iron regulation, and the role of hepcidin in iron, and what is iron recycling also. Factors that could influence iron absorption, like physical state, bioavailability, inhibitor like phytate, calcium, protein, competitor in animal study that lead cobalt, magnesium, and zinc, and iron facilitators like ascorbate, citrate, some amino acid with meat, fish, and pottery. What is the stage of iron deficiency? There is 3 stages: pre-latent iron stage, with this iron depletion, and also it is a stage of iron deficiency and rarely detected. Also ferritin store. Then latent iron deficiency, erythrobiosis, all indices like MCV, MCH, RDW, also ferritin are affected. And the last stage, which is a frank iron deficiency anemia, here the hemoglobin is associated with erythrocyte microcytosis, hypochromic anemia. This is the 3 stage of iron deficiency anemia. And now, what is the definition of anemia? WHO define anemia below 11 gram per deciliter for children from 6 months to 6 years old, and the children between 6 years to 14 years below 12 gram per is a risk factor for iron deficiency. We have many risk factors like dietary risk factor, cow milk consumption prior to 12 months of age, excessive cow milk consumption, formulated feed low iron formula, lack of iron supplementation after 6 months in breastfed infant, excessive weight gain. Also prenatal and neonatal risk factor like anemia during pregnancy, poorly controlled diabetes during pregnancy, prematurity, low birth weight, and multiple gestation. In infancy and the childhood risk factor, chronic infection or inflammation, chronic or acute blood loss, restricted diet, and use of medications that interfere with iron absorption like antacid. Social, like low socioeconomic status, and recent immigration from developing country are the risk factor for iron deficiency. Now we go to prevalence of iron deficiency anemia global around the world. Iron deficiency anemia account or affect 750 millions of children, also 30 to 40% of children and the pregnant women in developing country have iron deficiency. In Egypt, my country, this is a stage studies 2014, Department of Pediatrics in Shams University, which state iron deficiency anemia between 6 to 25 months, states that 43% had iron deficiency anemia. Also, in 2015, in iron deficiency anemia in Egyptian pediatric account from 6 months up to 12 years of age, it account for 64% studied children with iron deficiency anemia. And now, what is the impact of iron deficiency and iron deficiency anemia? Also, iron deficiency to impaired neurocognitive function, possibly irreversible cognitive defect, and lower academic performance during school children, also impaired physical development and poor appetite. This is a study shows the iron deficiency anemia and its impaction shows impaction in iron deficiency. She shows has negative neurocognitive, motor, and behavioral effect, and some with persist despite of treatment. She states that the cognitive deficit of iron deficiency may be irreversible. Iron supplementation is begin within the critical period from 0 to 24 months. Also, iron deficiencies that develop later in pregnancy lead to iron deficiency anemia has similarly been associated with impaired cognitive, behavioral, and motor development. The effect of iron deficiency without iron deficiency anemia is less clear. Here also, which is a Journal of Nutrition and for Science 2015, shows iron deficiency anemia in children and the alteration of immune system. They shows this result suggests that humoral, which have humoral and cell-mediated, which have an important role in various stable mechanisms, are influenced by iron deficiency anemia. What is the prevention for iron deficiency anemia? Here there is a primary prevention of iron deficiency in the first year and second year. In the first year, primary prevention is completely avoidance of cow milk. Also starting iron supplementation at 4 to 6 months of age, breastfed infant, using iron fortified formula when not breastfeeding. Iron formula should not be used at weaning, iron-rich diet and fortified food cereal. While in the second year of life, iron deficiency can be prevented by use of diversified diets that rich in source of iron and vitamin C, limiting cow milk consumption less than 600 ml per day, and use of follow-on iron fortified formulas and cereals, also providing a dairy iron fortified vitamin and treat the intestinal worm if present. And now, what is the screening of iron deficiency anemia? The first one, this universal laboratory screening and the CDC recommend the screening 9 to 12 months, then 2 to 5 years by risk group. For infant and toddler who didn't receive primary prevention before performed at 9 to 12 months of age, 6 months later, and 24 months of age later. What is the screening? The first one with screening is CBC, serum ferritin. Is a must CBC and serum ferritin, while in developing country who can't pay for CBC and serum ferritin and it is costly for them, we do what is called the therapeutic iron trial. What is therapeutic iron trial? Therapeutic iron trial, we give only hemoglobin level for screening of iron. Baseline hemoglobin, we do baseline hemoglobin, and then give iron 1 month, 3 milligram elemental iron per kg per day. Then we repeat the hemoglobin after 1 month. If hemoglobin 1 gram per deciliter or greater increase in hemoglobin, iron deficiency, baseline of hemoglobin is normal. This is the therapeutic iron trial for patient or for family for CBC and serum ferritin. Now we go to the treatment. The treatment began at ancient Greek physician who was drinking water contain a range of iron, rusted. The word had rusted. This is the Thomas Sydenham in 1684 This is the first one who use iron in a French wine. He use iron in the wine amount of 0.5 to 1 gram of iron daily. Here, we will go to iron supplementation, the new revolution for iron supplementation strategy, which is maybe we use traditional iron salt, we use lactoferrin, microdispersed iron, sun-active, what is called sun-active iron, liposomal sun-active iron, and amino acid chelated iron. First, it is the traditional iron, and all us know what is the traditional iron salt, which is present dated in the 17th century. Supplementation like ferrous sulfate, gluconate, fumarate, and polymaltose iron. This treatment challenge here with low iron absorption and side effect of this traditional iron. Low iron absorption here we use iron or salt ionized by HCl in the stomach, liberate highly reactive positive charge and mineral. This highly reactive bind to a lot of inhibitor like ethyl phytate in the diet, forming unabsorbed complex, and only 1 to 6% of total mineral intake is absorbed. So traditional iron is a so low bioavailability. Low iron absorption like in tannate in tea or phytate or in chocolate oxalate also affect. Side effect of this traditional iron therapy, as all we know, diarrhea, constipation, gastric abdominal discomfort. When iron supplementation are given in a liquid form, teeth may be reversibly discolored. Therapeutic dose, as we know, from 3 to 6 milligram per kg of elemental iron, even fumarate, sulfate, or polymaltose iron. Maximum dose would be from 150 to 200 milligram of elemental iron daily in severe cases. This is the traditional iron salt, and globally we use this traditional iron salt. What is lactoferrin and the role of lactoferrin? Lactoferrin multifunctional iron binding glycoprotein belong to transferrin family. What is lactoferrin? Lactoferrin present in many biological fluid like colostrum and like in milk, tear, saliva, vaginal secretion, seminal fluid, cerebrospinal fluid, plasma, and joint fluid. Structure of lactoferrin: N and C lobule. Each lobule is divided into two loops. N2, C1 and C2, both molecules bind to ferric ion, one on each other. What is the function of lactoferrin in iron deficiency anemia? The first is transport of iron. This is the first one. Also have antimicrobial activity, anti-inflammatory activity, anti-carcinogenic activity, immunomodulation, and antioxidant. This is a study shows in 2015 shows iron metabolism and the influence of bovine lactoferrin from iron fortified formula, who states that iron absorption increase in the presence of lactoferrin fortified milk. Also, a comparative study to evaluate the efficacy of oral lactoferrin fortified bovine milk with oral iron in treatment of iron deficiency anemia. This study is 2019 and concluded that oral lactoferrin is more effective treatment of iron deficiency anemia as compared to a traditional iron salt, with addition of clinical benefit and fewer adverse effects and better patient compliance. Also, we have, this is the second, traditional iron the first, lactoferrin the second, and the microdispersed new era. New evaluation. What is the microdispersed iron? The second category in a strategy of treatment. Microdispersed, what means that ferric pyrophosphate, ferric molecule, which are around in 8 micron. We use it in microionized form to be 0.3 millimeter mixed with emulsion so that it remains in suspension liquid form. As also we see, this is a ferric, microionized ferric pyrophosphate. It is microionized, average size 0.03 millimeter, are coated by emulsion layer to give high bioavailability and resist it against hydrochloric. Microionized ferric pyrophosphate developed recently used as a food fortificant. It is available in both liquid and dried form. In order to make a dispersible in liquid, the particle, as we see in a ferric pyrophosphate, is coated with emulsifier. Its principal advantage is being insoluble in water, and it is unlikely to cause many sensory problem. This is a study shows comparing the microionized iron versus the traditional iron, which shows a significant reduction in iron deficiency anemia among school children in India, which are is the ferric pyrophosphate. Another study in nutrition and health outcome in Egypt by Professor Tariq Al-Walili and Professor Rania Al-Haddad, which concluded that microionized iron is superior over lactoferrin, comparing with lactoferrin in treatment of iron deficiency anemia, where significant rise in hemoglobin, serum iron, ferritin considered. Microdispersed iron has less side effect and more compliance. Also, iron deficiency anemia need more effective treatment modality to be adopted compliance and play an important role in its choice of treatment. Ferric coated by emulsion. Also, comparative study between dispersible ferric pyrophosphate particle and the ferrous sulfate in treatment of pediatric patients with iron deficiency anemia. Here, the conclusion, microdispersed iron could be used as an alternative therapy for children with iron deficiency anemia who refuses oral iron therapy in a liquid form, with more tolerability and less side effect. The next one is the sun active iron. Sun active is a commercial term, and this is developed by a Japanese company which form sun active microionized iron by a phospholipid layer called sun active, a combination of a nanotechnology and the encapsulation process is called the super dispersion, is behind the development of sun active iron. Sun active iron is high tolerability and high bioavailability, more than a microionized iron, and can't be destroyed under high presence of styrene and the presence of glyceride and lecithin. This means that this is a soluble iron salt, and this is sun active iron and insoluble. We see it with sun active iron means a ferric iron like microdisperses coated by emulsion layer, not emulsion layer like microionized iron, which contains surfactant and co-surfactant. This is a phospholipid layer, which resulted destroyed under high temperature of iron. And here we see another evolution is put this sun active iron, microionized iron with phospholipid layer in a liposome. Its absorption and increase its bioavailability, both in liposome, which is called the liposomal iron or liposomal sun active iron with two layer phospholipid, which increase its absorption. Liposomal iron as a composition of the outer membrane, liposomal iron is like that a biological membrane. different mechanism and maybe instrumental in absorption. Mechanism of absorption, which give you highly absorption. First one is a simple absorption, which increase local concentration of liposome, or it may be with endocytosis or fusion by liver oil exchange. This is the iron and increase absorption by 4 mechanisms. Simple absorption, maybe endocytosis with fusion of lipid bilayer, phospholipid layer and brush membrane, also exchange of the lipid membrane like we see. This give an enhancement of absorption more than sun active iron. This can ultimately result in better bioavailability of iron. This is a study. Although this is not evident in children, all studies performed in liposomal iron performed in adult and the pregnant woman. Until now, there is no study present in liposomal sun-active iron, or what is called the liposomal iron coated with liposome for absorption. This is a study of treatment of iron deficiency anemia with liposomal iron in inflammatory bowel disease, which concludes that in summary, this pilot study provides data supporting therapeutic uses of oral liposomal iron mild iron deficiency anemia with IBD. This is in adult only, and as I said before, there is no study till now in liposomal iron efficacy of children. Also, oral ferric pyrophosphate coated with liposome abstract and concluded that oral liposomal iron is as effective as a microionized iron for treating iron deficiency anemia, but with more absorption and high bioavailability. We still need more and more researches on this form of iron, which are called, as we said, liposomal iron. The last one of the revolution of iron therapy strategy is the amino acid chelated iron. Amino acid chelated, which is iron chelated. Chelation is the chemical bonding processes resulting from the reaction of the metal iron a soluble salt with amino acid chelate. What is the type of amino acid chelate? We have a ferrous biglycinate chelate, ferric triglycinate chelate, ferric glycinate, and the ferrous biglycinate hydrochloride. But most important is the ferrous biglycinate chelate. It is the most studied and used for. What is the structure of ferrous biglycinate?
2 minutes.
Ferrous biglycinate is the ferrous molecule, which is with 2 identical chelates, which is glycine. Ferrous with glycine, acid biglycinate. Adaptive bond of nitrogen stabilizing the energy center. Here shows the stability of the bond, which does not hydrolyze and inverse gastrointestinal effect. Also, new iron strategies include adding lactoferrin to iron, microdispersed iron, also sun-active iron, and also liposomal sun-active iron or liposomal iron as a new strategy for iron supplementation. And lastly, amino acid chelated iron.
Thank you, Professor Wael, for this very informative presentation. And stay with us, please, if there is any comment or any question from the audience. If there is any comments or question to Professor Wael, please. Dr. Ali Al-Mahidi.
Thank you very much, Professor Wael, for this excellent presentation. I have 2 questions. Number one, regarding the cost of all these, new developments in iron, therapy, this is one. As you know, in some, underdeveloped countries, it may be more expensive than the traditional iron therapy. This is number one. Number two, do you have any idea about using intravenous iron for patients who have malabsorption? Especially with IBD, we see a lot of patients coming with very low hemoglobin. They have inflammatory bowel disease, and we have used IV just to, correct the iron deficiency anemia before they need, blood transfusion.
Yes. Thank you, Professor Ali Mehdi, for this two questions. First, congratulations for this highly scientific and organized conference. You hear me? Please.
Yes, we hear you. Yeah, go ahead.
Yes, okay. First, I know that chelated iron or liposomal iron or microdispersed iron is costly compared to the traditional iron, but not far by much. In Egypt, traditional iron cost 20 to 25 Egyptian pound, and new iron revolution like lactoferrin or sun active iron or liposomal sun active iron or even chelated iron 100 pound. Here we got not to the price but also to the high bioavailability and less side effect. I said for that, but it is not in Egypt, not costly as you say, yeah. The second question is I have no experience with intravenous iron in IBD patient. We use it in errors in severe cases in pediatric ICU with severe anemia, but I have no error in cases of IBD. Thank you.
Any more questions? Thank you very much, Professor Wael, and have a good time. So we'll go proceed to the third speakers. Our third speaker is Professor Sana Yusuf Shaban. Professor Sana is a consultant of pediatric clinical nutritionist, and she is the president of Arab Society of Pediatric Clinical Nutrition. She's going to talk about the obesity rising medical problem in children and adolescents. You have 25 minutes for your presentation.
Good morning, everybody. I cannot share the screen because
Prof. Sana, you have a green button down in the app.
I know, but it was shared by the other speaker.
Okay. Yeah. Okay, we can share it and just.
Okay. Assalamu alaikum. It's really a privilege for me to be in this prestigious event. And I would like to thank the organizing committee of the SASPGHAN for giving me the chance of being a part of this event. And very special thanks and deep gratitude to my dear Professor Ali El-Mehedi.
Professor, can you please do full screen in the PowerPoint?
I did it full screen.
تحت في البار اسفل فيه علامه الفول سكرين في اليمين جنب 50%.
كده اوكي. It's still not full screen.
ممكن تعملين شير الديسكتوب؟
أما هو من الديسكتوب الشيرنج بتاعي.
طيب فيه البتن تحت يا دكتوره، في مكتوب 50%، فيه ايكون جنبه، ممكن تعملين تضغطين عليها فقط.
ما عنديش ايكون تحت.
خلاص اوكي.
Okay, I'm sorry. Okay. Now, my talk today will be about when you see an obese child, what does this mean to you? So, by definition, the obesity, it's a condition where there is an excess body fat.
دكتورة سناء, your slide is not moving.
It's the same problem.
So we have the recorded video. Can we run it and we can?
Just a second. If not, then we have to run the recording. I will do a new share. I'm sorry. Is it okay?
No, still.
Not still. I don't know.
طيب ممكن تعطينا بس سماح ان نتحكم بالشاشة حقتك؟
Okay. Okay. Okay.
Well, still there is problem. خلاص يا دكتورة, we can run the recorded
Okay,
lectures.
you can run it and I'm here.
Yeah.
Okay,
thank you so much.
Thank you. Hi everybody. Assalamu alaikum. I would like to express my deepest gratitude to the eminent SASPGHAN for giving me the chance to be part of this excellent meeting. And very special thanks, Professor Ali Meheda, for inviting me to be one of the speakers of this eminent event. I'm Professor Sana Youssef, and I will talk with you today about the childhood obesity. I wished to be among you, but something out of our hands has come because of the corona. Hopefully next year we'll be together. Thank you very much. Now, to start with, what does childhood obesity mean for you? When you hear this word, what are you thinking about? It's a new pandemic. Now, the childhood obesity is a new pandemic invading the developed countries as well as the developing countries. It's all over the world, and it is really serious because of its complication. Now, the WHO has been defining that the obesity is a condition where there is an excess body fat and it negatively affects the child health. The problem is that it is involving many systems, problems with complex and interconnected causes. You cannot, this goes to this, leads to this, and so on. So they are interconnected. And obesity is number one contributor to the poor health nutrition-related chronic diseases later on in adolescence and adulthood. Why it is so important to tackle this problem? Because this pandemic is introducing our children to illnesses they never knew it before. They are new illnesses to this age group that were once commonly used only for adults. Now, coming to the etiology of childhood obesity, we should of course know that we have a genetic predisposition and we have the obesogenic environment, which affects our genes and leads to a word which is known as the epigenetics, which are new modifiable forms of the genes. They do not change the DNA sequences, but it changes their expression from person to person. Genetic plays, of course, an important role, but the obesogenic environment is crucial, especially the parental, the social, the lifestyle, physical activity, the sleep pattern, and the culture, the new culture which are invading us with everything. And also the economic factor is very important. On top of more and above, on top of these two main criteria, we have the microbiota. Now, we all know that the GIT is the house of immunity, and it is the house where you have, it is the key player for your immune system. 80% of your immunity resides there. It's also affecting your brain through the microbiota gut-brain axis, and all this depends on the type of nutrition you are going to feed. So when you eat, you are not only feeding yourself, you are feeding the microbiota, which are the regulator of your whole life. Now, due to the nutrition transition which has happened lately in the last years, and the shift from the traditional healthy diet to the junk food, the fast food, the delivery, and all the foods which are present on the market, in the shops, in the supermarket, this has changed your microbiota very much, and accordingly, it has changed your immune system, and it has changed your way, also behavioral affection. And this is mainly resulted in what we know as the obesity. We did not have all these types of this incidence of obesity in the era before. Now, what are the most important three driving factors for obesity? If I ask you this question, is it the genetics? Is it the physical activity? Is it the healthy eating, the lifestyle, or the medications? Certain medications such as the antipsychotic, steroids, antidepressant, they lead to obesity. So eventually, the most important three factors are the physical activity, the healthy eating, and the lifestyle, whether you have a sedentary life or an active life, because they have more impacts now on your health, more than the genes, and of course, medications are something which are personalized. Now, childhood obesity gives you a high risk for a high blood pressure, a type 2 diabetes, a sleep disorder, asthma, depression, behavior and learning problems. Is all the above is true? Is it true, or which one is the most important risk factor due to obesity? Eventually, they are all true, and there is even more. High blood pressure leads to cardiovascular diseases and strokes. Type 2 diabetes is going to affect the liver, and it is really serious to control it. The sleep disorders affect your lifestyle. You do not have time for exercise, or you are too tired to have exercise. The asthma, because the diabetes, the obesity affects also the respiratory system, whether in the form of the sleep apnea or sleep disorders, or increasing the incidence of asthma. Depression because of the low self-esteem, because these children are always bullied by their peers, whether in the clubs or in the schools, wherever they are. Then this ends up in behavior and learning problems because of the too much sugary foods, and this is known, and all these group of foods with lots of preservatives, lots of coloring, and so on, and flavors, and these are known as the brain fog foods. Now, how to diagnose a child with obesity? Of course, the history is the main pivot, where you have to know the age of onset, because we have too early onset or we have a late onset, and this makes a difference. We have a gradual onset, slowly, this means it is due to diet, and we have a sudden onset. This would be definitely due to an endocrinal causes, which has changed suddenly the profile of the child. And the dietary history is the clue for your diagnosis. The dietary behavior, how these children eat. Do they have any feeding problems or eating disorders? And the dietary pattern. Is it a structured dietary pattern where we have breakfast, we have lunch, and we have snacks? Or is it too much snacking day and night, 24/24 hours? A healthy behavior, which is mainly the lifestyle, and we mentioned the sleep, the extreme watching of the TV or the work on the computer or the laptop or the iPad, whatever. And then you have also to see if there are associated, you have to ask if there are any associated comorbidities or not. The anthropometry examination is very important. Well, the anthropometry is the mainstay for your diagnosis of your child. We have the physical examination, especially focused clinical signs of a comorbidity, such as the acanthosis nigricans, the stria, the intertrigo. You have to look for the chest and the respiratory system, cardiovascular system, the abdomen, and where is the fat mainly seated? Is it a central obesity, or what is the type of clinical examination which you have performed, which leads you to the clue? Then we have the lab test. For simple obesity due to increased food intake, we simply do a very simple CBC and an iron profile, and we are going to go also for the presence of micronutrients, because these children are usually micronutrient deficient. But unfortunately and unhappily, now in these last few years, children are coming to us to lose weight, and if you do think that they are the presentation for type 2 diabetes. And this is very sad, because the obesity has escalated their general health. The diagnosis of childhood obesity, when we use the anthropometric measurements, whether it is the weight, the height, the waist circumference, and the whatever you are measuring, the most important point in the diagnosis is the BMI. But BMI cannot be used before the age of 2 years. We have special charts for girls from 2 to 20 years, and special charts for boys also from 2 to 20 BMI. Now, if the child is on the 5th centile, this means that he is underweight. If he is on the 5th centile, this means that he is of a proper weight. If he is on the 75, he is still on the proper weight. From 75 to 85, this is the start of the overweight. From 85 to 90, this is an overweight, a real overweight. And from 90 to 95, it is mainly obesity. So you have to clarify, where does your child stop? From 85 to 95, you can consider them obese. but this is an early stage. This is a late and very serious stage. These are the BMI charts which you should use when you are diagnosing your child whether he is obesity or not. Now, most obese children are above the 5th centile. You have to put this in your mind for height. And this will differentiate them from any other endocrinal causes, which is usually associated with short stature because of the decline in the velocity of growth. So if you have a normal height or an excessive height, most probably you are dealing with an exogenous obese causes, which is mainly due to food. If you have less than the 5th centile, then you are dealing with a genetic or an endocrinal causes. And this is a clue to first, you are going to standardize your children on which side they are. Now, the WHO has classified childhood obesity as follows. For children under the age of 5 years, overweight is the weight for height greater than 2 standard deviation and above the WHO child gross standard median, while the obesity is weight for height more than 3 standard deviation above the WHO child gross standard median, because in infants less than 2 years, we use the weight for height charts and we do not use the BMI. There are no charts for BMI before the age of 2 years. Children from 5 to 19, which are our concern in this lecture, they are considered to be overweight if the BMI for age is greater than 1 standard deviation above the WHO gross reference median, and obese if the BMI is 2 standard deviation above the WHO gross reference median. BMI is the best single index to diagnose obesity. Now, this slide is mainly, eventually, we have done a guideline for the health practitioner in Egypt to help them when they present to them in the primary care, how to spot out these children, how to spot them, and how they will deal with them. So if children or adolescents have a BMI more than 85 percentile, you have to take a very meticulous history, including dietetic history, family history of obesity, whether all the family is obese or not. And then you do a focused clinical examination for signs of obesity or complications of obesity. If this is normal, then you evaluate any comorbidities which are present. If the comorbidities are not present, then you will simply do a lifestyle modification of the diet, of the sleep time, and of the physical activity. If there is something abnormal, then you have to do a lifestyle modification plus the treatment of comorbidities, whatever is its type. Now, if there is a gradual weight loss, then you maintain the lifestyle modification and the treatment of comorbidities, and you are improving, you are on the right track. But if there is no improvement and you are still gaining weight in spite of all this, over the last 6 months, then you have to consider aggressive treatment such as the pharmacotherapy or the surgery. Tracking from the start, if the history and physical examination are abnormal, then you should do an additional evaluation for the underlying disease, whether it is a genetic cause, an endocrinal cause, or a CNS injury. And here, the height would be a good addition for your diagnosis. Where to start for the management? A successful treatment of childhood obesity is really challenging. It is really difficult. It is one of the most challenging management. The first step is to diagnose the etiology. And this is done, as we said, through the history, assessment, and the interpretation, proper interpretation of the assessment. And then you put your diagnosis. Then the second step would be setting up a goal. Anything you wanted to succeed, you must have a goal to reach. So you have for these children to define a realistic goal, something which you can do, not something which you can imagine. They will not lose weight in 1 week or 1 month or 6 months. You have to be patient, and you have to do a multi-phase target. Phase 1, how much to lose, or is it simply stabilizing the weight? Stage 2, how you are going to proceed, whether you have succeeded in the first stage or not, and whether the late stage you are going to add on pharmacotherapy or you'll go to surgery. So when setting the goal, it is very, very important to be realistic. Then we design the strategy. How would I manage my child? What is the strategy I can use? I'm going to select the type of intervention. Is it a dietetic only or what? And then I also select a program of education of the child and all the family and all the surroundings. Then I support my management if it is succeeding, and I have to monitor and reassess myself, and every now and then, if I need to change something in my strategy, I must change it. I should be flexible according to many conditions. When you are dealing with an obese child or obese adolescent, he is not one part. It's a whole complicated, interrelated system of people. No one can succeed alone, definitely. You have stakeholders for children with obesity. The mother, the father, which are quarreling all the time about her being very restrictive. We have the sisters and brother who can be bullying. You have the grandmother, as we have it here in my country, in Egypt. They are always thinking about making their grandchildren chubby. They still have the concept that chubby baby is a healthy baby. So you need a whole work out, and even the teachers in the nurseries, teachers in school, and in the physical or the sports trainer in the club, all these, they need to be on the same way and on the same track to manage my child. You cannot do it. You cannot have the child alone. You will never succeed. How to start with the management? It includes 4 stages. The first stage, of course, it is the best and the easiest and the most successful, is the prevention. The second stage would be the structural weight management. Then the third stage would be a comprehensive multidisciplinary intervention. And the last stage is, unfortunately, the intense approach for the very severe obese child. Now, prevention is better, of course, than cure. And you have to know that prevention starts very, 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 very early, antenatal, even young girls to be married, to be mothers after this, they have to keep their weight, because an obese adolescent would be an obese female, would be an obese mother, and so on. But you have to know that generally, in the general population, when parents are not obese, there is a risk of 20% of their children to be obese. If one parent is obese, there is a risk of 40% of their children to be obese. If both parents are obese, then there is a risk of 60 to 80% of having their children obese. Of course, we start with the breastfeeding, which we mentioned many times before. This is the first step on the right road. and then the timingly and the proper complementary feeding. This is the second step. These are the windows of opportunity to have a healthy, a slim or well-to-do child. And you do not start the complementary feeding with extra calories food. This is very important. Now, this is the guideline for obesity prevention according to the WHO. I love it very much. These are the 5, which means 5 serving of fruits and vegetables per day. 2, screen time, keep it less than 2 hours per day. 1 is for be active for at least or more 1 hour per day, and 0 is for sugar or sweet drinks. If you take 1 and 0, this is equal to 10. You should have 10 hours of sleep. If you take 5 and 2, this makes 7. And you have to start the day with breakfast on daily 7 days per week. And this is one of the problems you are now facing, that most children go to school without a breakfast. The common nutritional recommendations for the control of obese child is the portion size. We are going to the huge portion size, which is incredible. The portion size should be controlled and well balanced. The mode of eating, we are not taking bite by bite and chewing. Children are just swallowing the food. This is known as gorging, and this is the ends in obesity. Then when you come to the choice of the food, you have to choose a carbohydrate restricted or reduced, depending on what is happening, a low glycemic index food for children and adolescents, or lots of fiber and low fat. You are not allowed to use low fat or non-fat products before the age of 2 years because of the brain and the nerves, the central nervous system. They are all made of fat, and he needs the fat for their proper formation. Then at the older age, you can do also elimination. And for older children, elimination is easier and you can control it if you convince them. Now, this is the healthy eating plate, which has to go through all stages of life. Half of your plate should be made of fresh fruits and vegetables, less than quarter of whole grain, and the rest is mainly a protein. Whatever the type of protein, and don't forget the water. Water is a nutrient. It is not something which is extra. It is a nutrient which you need for the proper function of the cells of your body. And when you need to use oils, you choose the healthy ones. Now,
She disconnected?
But we are running out of time, and we can take her questions.
She can hear us now?
Because still there, yeah, she's hearing us. Prof. Sana.
Prof. Sana, can you hear us?
yes.
Okay. So thank you very much for your talk. Was very impressive. Thank you very much. We'll just open the floor for questions. If anyone has a question.
I'm Dr. Mukhlis Alam, practitioner, pediatric practitioner. I would like to emphasize and to recommend for everybody of us to go to the political stages and ask all the people who are involved in laws to limit the importance of marketing, of food marketing. They have a huge impact on our children and on our attitude. All over the world, there are some consumer clubs actively working to stop the intervention of these marketing people into our lifestyle. Thank you.
Thank you. There is a question here.
Good morning. Thank you, Professor Sana, for this presentation. I just want to ask about your experience about the usage of Orlistat in obese children. Have you ever used it, and what about the result for it?
Yes, there is in my presentation. Thank you very much for your question. There is in my presentation for very severe obese child at the end, those who have a body mass index more than 30 kilogram. And this is mainly, we have the Orlistat, but it is used only after the age of 12 years. We have the metformin. You can also use it after 12 years. And lastly, now on the market came new the Saxenda, which is Ligartitude. And this is also allowed, and it has been FDA approved. The three of them are approved after the age of 12 years, which means that you can use it in adolescence. And in my presentation, the dose is written. If after using these medications, and in spite of this, you are not still, the child is not still losing weight easily, then you have, unfortunately, to go to bariatric surgery. And we have lots of experience in Ain Shams University, where we cooperate the pediatric department with the pediatric surgery department. We have done so far until down to the age of 10 years. This was the youngest child, and it is very successful.
Okay, I have a question to Dr. Maher. I understood from your presentation that Larustide is assisted by clinical response. Do you have any?
Can you raise your voice, please?
Do you have any idea that you can assess the efficacy of treatment histopathologically or laboratory by testing the antibodies?
No, unfortunately, we don't have this experience, no. We just
this is a question to Dr. Maher, Prof.
Thank you.
Thank you very much. So Larazotide is very effective if was given with those with the gluten-free diet, one gluten-free diet, and you do have still some symptoms or elevated in the antibodies, but it has nothing to do to control with the either the mucosal healing or the recruitment of the intraepithelial lymphocytes. So it's just adjuvant therapy for the gluten-free diet.
Okay, any question? Yes, there is one.
I'm Dr. Ala, General Pediatric Consultant. Thank you, Dr. Maher, for this wonderful presentation. I have a question regarding the clinical use of the HLA DQ2 and DQ8 in the as a screening and diagnostic tool for celiac disease. And is it replacing the duodenal biopsy? And what's your current practice regarding this?
Yeah, sure. So we talked today about the using the HLA to the DQ2 and 8 as a blocking agent for the ABCs to not to recruit more antigen-presenting cells and progressing of the inflammatory reaction inside the subliminal level. Using of the HLA DQ2 and 8 for diagnosis of celiac disease, there is a certain indication when we ask the family or the patient to do it, when we have a query or unclear celiac disease, when we have mismatch between the histopath finding as well the serology of antibodies like the deamidated anti-gliadin. We may use that one to confirm the diagnosis. Replacing the biopsies, I think with the new guidelines, all the committees are going with the excluding maybe the biopsies in the near future.
Okay, there is one here and one here.
Thanks for all speakers. My question to Prof. Sana regarding breastfeeding in the past was predisposed to obesities. So any explanation, any environmental factors?
Thank you very much, Dr. Susa, for your question. Well, breastfeeding, if the mother is obese, it can lead sometimes to obesity. And this is one of the proposed theories. Eventually, now we are speaking about how it prevents obesity on the other hand. But sometimes some breastfed children, they become tremendously huge, overweight. For example, I had a 3-month-old girl with a weight of 8 kilograms, which was heroic. Now, in this condition, we advised the mother to make spacing in between the feeds. And not every time the child cries, she feeds him. She tries to do anything else. Spacing is our only management we can do for at that time. And then we compensate for it because we are trying to stabilize the weight. Stabilizing the weight is a very important issue when we are speaking about the management of obese, whether infants, children, adolescents. We start with the stabilization because sometimes children, they grow in it, which means when they become taller and with the time, this would be eventually suitable for their age. So this is a very important step. Before we start looking for losing weight, we have to manage to stabilize the weight for some time. If in spite of this, you are still adding, then you have to go to a management where you have to, in a way, to restrict some foods. And most important, when you come to weaning or complementary feeding, then you have to choose foods which do not give too much calories. You go for fruits and vegetables, or vegetables mainly. You go for lean meat, you go for foods without extra calories, and of course, no sugars and no sugars in any way, whether liquid, whether in the form of sweets, whether in the form of juices, no sugars at all. Does this answer your question?
Thank you very much, Dr. Sana, and thank you for all of our speakers. I think we reach at the end of our first session. Thank you very much, and we'll go for the next one.
Thank you very much. It's been a pleasure joining you.
Excuse me, there is no break. We'll start the second session now. The break after this session, inshallah.
Assalamu alaikum, everyone. Good morning. I'm Dr. Fawaz Rifai from Kuwait, consultant pediatric gastroenterologist. I would like to thank the organizing committee for the kind invitation and congratulations for the success of the 7th International SASPGHAN Congress. Without any further delay, I would like to introduce a speaker for the special lecture, Dr. Mohammed Hassousa. He's a well-known figure of pediatric gastroenterology in the kingdom, globally and internationally. He has a rich CV with more than 51 publications, and he's associate professor at National Guard Hospital and section head of pediatric gastroenterology. The topic will be about hot area in the field, which is probiotics in clinical practice, why, when, and how. The floor is yours, Prof.
Assalamu alaikum wa rahmatullah. Thank you, Chairman. Thanks, Sanofi, for this invitation. And special thanks for you for attendance. I'm going to present the probiotics in clinical practice as evidence-based medicine what, why, and when. So briefly, I will talk about what's microbiota, what's the organism. Then we'll focus on evidence-based medicine practice in probiotics, especially in pediatric. Then I will show you some local data regarding the probiotics. Well, what is the power of microbiome? Hippocrates said, all diseases begins in the gut. Is it true? Why? Because almost 100 trillions of bacteria in the gut is almost 100 or 1 times of the human cells. And even though the human have 23,000 of the genes with the to be microbiomes, so in addition to that, the microbiome will be almost 150 times that microbial genome. So we didn't surprise. We didn't surprise that 70% of the immune cells localize in the GI. So this is the summary, how's these microbiomes in your bodies. And I'm surprising that almost 2 kilos in your bodies constitute microbiome. So if your weight 80, so reduce or make it mad that it is 78, that it is microbiome. And even though you have each individuals has unique microbiomes like fingerprint, and I'm not surprised maybe they use it as a passport to go to abroad. So whatever discovering or great of interest that every day they discover more and more about probiotics. So we know that the microbiota starting initially at the critical period at the age in the first 3 days, affected by the mode of the deliveries and affected by the genetics. So then after in the next 100 days, the microbiome affected by the feeding types and environmental exposures, and you will see a lot of or different anaerobes and bifidobacteria constituting all in your bodies. Well, in human bodies, especially in the GI, so you will see a varieties of the almost 100 to 1,000 species of the bacteria. And the most common location was in the colon, up to 10 to the power 10 CPU, mainly bacteroid and bacillus. However, you may discovering more and more about this microbiome, including anaerobic and aerobic bacteria. So this thing that not where you are gastroenterologist, that the GI has intelligence system, defense system that have 3 mechanisms, including gut-associated lymphoid tissues and microflora and its tunnel-like mucosa. So regarding the gut, so it is one of the most important defense, showing that it is one of the most immune largest organs, and almost 70% will secrete IgA, and usually involving the lymphocyte, and usually located in the Bayer patches and in isolated lymphoid follicles with the subinterfilial lymphocyte, including scattered lymphoid and organized lymphoid. So regarding the gut microbiota is being affected, and I will not go in detail about this, usually affecting by the mode of the deliveries, affecting by the diet, affecting by drugs and the genome. But the most important that the microbiota has been well to improve or to support the barrier by increased mucin production and decrease permeabilities. In addition to that, it will help to stimulate humoral immunities and cellular immunities by secretion IgA and balancing T cells helpers. So gut microbiota play important in the maintaining health. So absolutely probiotics are believed to augment it further. So by definition of WHO and FAO and SAPP, state agreed that probiotics as live microorganism, when administered in adequate amount, it will confer to health benefit in the host. However, not every probiotics in the market is a probiotics. It must include all of the following. It must that should be identified genus and species, should identify that it is not pathogenic, should be viable, resistant to the acid, should be stored in the good amount, and should have sufficient numbers of the viable cells, and should be undergo in vitro and vivo to have demonstrated as probiotics, and at the end should be anti-inflammatories and immunostimulatories. So this is the summary, but should add that it should be human origin and should have antibacterial activities. So the mechanism of the probiotics, it's a little bit complex, but I make it more simple that usually the first thing is the enhancement of the epithelial barrier. Then it will have increased adhesion to mucosals. Then it will have competition of the pathogenic microorganism. Together will have production of antimicroorganisms substances. And at the end, it will have modulation of the immune system. So modulation of the immune system, it means that you will have secretion of the immunological defense. You will have introduction of the TR cells with intercellular cytokines, and you will have activation of the natural killer cells. And at the end, you will have modulation of adaptive and innate immunities, including cytokines. It is complex, but I make it more easy that immune stimulation is very, very important. So beneficial of the probiotics, you expect that it will improve in lactose absorption, is improve in digestion, is improve in cardiac, is improve. So you will see more and more. Why? Because we increase awareness of the probiotics. It's been well known that being discovered more and more. So you didn't surprise that probiotics being received or treated for any age diseases. So when I go literature review, deep literature review, I found that the two organisms involving in the bacterial, it is bifidobacterium and lactobacillus. While enterococcus and lactococcus and streptococcus and bacillus are accounting the minor. So the majorities is mainly lactobacillus and bifidobacterium. So now we'll go to the evidence-based medicine. So what's about this meta-analysis? So if we see that H. pylori, there's growing data that it's been helped in treated of H. pylori. In IBD, when known that in adult UC using as induction and maintenance, but there is no or enough data in pediatric. Constipation, yes, there is a growing to see it, and antibiotic associated, it's been associated, and others like C. diff and chemotherapies. From the gastroenterology or American GA, they grade the probiotics as grading system, and absolutely we agree that it means reduce antibiotic associated diarrhea with the great evidence A, both in pediatric and adult, and also it happens or it will work in the adult ulcerative colitis, and at the end it will help in necrotizing enterocolitis in neonate. While others grading B, including C. diff, including hepatic encephalopathies, including others like pancreatitis and Crohn's disease. So let's go one by one quickly. So if you see this is Cochrane reviews by antibiotic associated diarrheas, if you see that the incidence of the diarrhea comparing to the treatment and comparing to the placebo is favor probiotics. So nobody will argue with us that if you have antibiotic associated diarrhea, it will work. However, still there is lack to use what's the dose and for how long. So still ongoing, but this meta-analysis showed. And most important that in pediatric, you will see that it's favor antibiotics with the I-square almost 64% with the significant p-value. So at least we have strong evidence that probiotics may help in antibiotic-associated diarrhea. What's about constipation? It is not convincing to us if you see this meta-analysis, and this meta-analysis that had been shown that not significant p-value, and there is growing evidence you may use it in refractory. This is in my next lectures. What's about H. pylori? Yes, it's been growing evidence that you can use it not as a sole treatment, you can use it as adjuvant, or if you have refractory H. pylori, you may use it with adequate dose to eradicate H. pylori. So regarding infantile colic, which is the most important and the most convenient to us, that Lactobacillus reuteri that is being shown to decrease the effect on the success rate and decreasing the crying times, and with significant p-value on this meta-analysis. And the mechanism, they said, is due to calprotectin by cytokines. And once you give probiotics, you will have balanced gut microbiome. So the fecal calprotectins and other cytokines will reduce. So we have at least strong evidence that probiotics help in infantile colic with the breastfeed only, not in formula fed only. Regarding gastroenteritis, when I search for it, there is some conflicting data. So I found that some of the probiotics, including Lactobacillus rhamnosus and Bacillus, it is moderate evidence. But again, still, it's not clear to use it. However, you may use it with the ORS, with other supplement for gastroenteritis. But if you see from the GBN, they didn't recommend it strongly to use it gastroenteritis. However, not all probiotics are the same, and this is the main problem for us. This is regarding the diarrhea. If you see the diarrhea, the meta-analysis for acute diarrhea, it will reduce the duration of the diarrhea and it will reduce hospitalization by, in this 12 RCT, show that the mean difference was almost minus 21 hours with significant or the p-value. So using probiotics in acute diarrhea with the adjacent with the ORS, it may help. Regarding probiotics and reflux, although there is some little data, it is insufficient to use probiotics in reflux. So again, we need more data to start probiotics in reflux. The most interesting by Prof. Faleh found that meta-analysis that probiotics, it work in necrotizing enterocolitis with the risk ratio almost 0.4, and even the reduced mortalities. And again, when I asked my colleague, a neonatologist in Kingdom of Saudi Arabia, they didn't use it unless if there is the incidence of NIC is common, they use it. So the MOH proposing a protocol where the incidence of NIC is common in the NICU, they use probiotics. But in clinical practice, they still has precaution to use probiotics, especially if the preterm less than 1 kilos. So this is network analysis shows that the larger node mean the larger numbers, and the thickness of the lines mean the increase the number of the studies. And when known that Lactobacillus and Bifidobacterium using for necrotizing enterocolitis. And again, multiple meta-analysis showing that it will convince us that to use probiotics in necrotizing enterocolitis, but the problem is which strain, which the dose, and how long. So still there are disagreement about this. However, in spite of there is strong evidence, still we need more data on the duration. Regarding the Bacillus croaces for acute diarrhea or acute diarrhea children, this is systemic review and meta-analysis, and you see that they reduce the duration of the diarrheas and the duration or hospitalization by significant p-values, and you see the mean difference almost -9 hours, and here the mean duration or the mean difference -0.8 days. So at least once we have safe probiotics and with good efficacies, with the good evidence for this meta-analysis, it will be provided to use it. And another studies regarding Bacillus croaces for acute community diarrhea. And if you compare between antibiotic-associated diarrhea and viral diarrhea, it being reduced or effective and uses as adjuvant treatment for acute diarrhea. And again, it has good safety profiles with comparing before and after treatment. This is another studies shows the effect of the Bacillus croaces in reducing adverse effect from H. pylori eradication. And again, you will see that attention to treatment that it will be significant. So there is some evidence and some strong data use this Lactobacillus croaces. So again, comparing to the placebo, is to reduce the incidence and the number of days with the diarrhea receiving H. pylori eradication, and it's well treated. So agreed with that, we use probiotics in necrotizing enterocolitis, in antibiotic-associated diarrhea, and sometimes in acute diarrhea. So we conducted studies to see what's the awareness of pediatrician regarding probiotics in Saudi Arabia, all part of the kingdom. And we found that when we asked them what's the definition of probiotics, unfortunately 40% know that the definition of probiotics. So for this, almost some of them, they state it's dead, and some of them I didn't know. And if you see the practice of this pediatrician, when you ask them about what is system you think is affected, yes, they agree that is the GI system. But when you ask them why you are prescribing probiotics, it is heterogeneous. Some of them, they said, to improve GI digestion. And the most important they ignore is antibiotic-associated diarrhea. And some of them, they answer that they reduce allergic. So there is a gap in knowledge and gap in practice regarding these probiotics. And also we ask them, do you use it acute induced diarrhea? Most of them are 50-50. They not aware about probiotics using in acute diarrhea. And even though when I ask them, do you use it before and after meal? Again, they don't know. So this is why we conclude from our studies that there is a significant difference in knowledge and practice among pediatricians in Saudi Arabia. And even though we conclude that this identification of these risk factors or this knowledge gap will help us to develop educational materials to improve the definition, to improve knowledge, and to use probiotics, because nowadays it is widely used in markets. So we need to minimize and to put it in as evidence-based practice. So this is why at least we have some data on it. So the problems, when I review literature, that why probiotics is limited in routine practice in all GI or in pediatric practice. Number one is the strain specificities. Number two is the dosage. So until now, nobody know which one is better. Number three, matrix duration of the probiotics. What's the route of administration and indication, and the safety, which is very important, of probiotics in pediatric practice. My conclusion, gut microbiota play an important role in maintaining gut health, and probiotics are believed to augment it further. And there are 3 defense mechanisms on the GI, including GALT, microflora, and intestinal mucosa. And the mechanism of these probiotics in immunomodulation, including secretion of the immunological defense, including interaction between dendritic cells and TLR, and activation of macrophage and neutrophil killer cells, and modulation of innate and adaptive immunities. And again, there's evidence-based practice regarding probiotics, including antibiotic-associated diarrhea, gastroenteritis, inflammatory colic, and necrotizing colitis, and UC in adult, but not in pediatric. And at the end, if anyone is interested, this is updated guidelines in American Gastroenterology Association, was very clear, put it in the pediatric and adult. And at the end, I wish you to enjoy my lecture. Thank you very much.
Thank you very much, Prof. Hassousa, for the excellent comprehensive review of such important topic. Open the floor for question. We'll get a couple of questions because of the time, please. Yes. Fadai. We need a mic so they can ask.
Assalamu alaikum. Thank you so much, Dr. Muhammad, informative lecture as usual. My question is, as you know, the probiotics, it's not all the hospital they can provide it to the patients. Besides, also in the outside pharmacy, most of the insurance company, they will not cover it. Most of the patient actually, they order it online, and it's so expensive. Do you think as a gastroenterology, we're gonna have the rule to consider this as essential medication, and we have it in all hospitals for our patient? Thank you, Muhammad.
Thank you, Dr. Sharifa. Well, probiotics is complementaries. It is not a medicine. This is one of the how to convince the institution system. But again, Dr. Sharifa, if you see the evidence-based medicine regarding probiotics in pediatric, especially antibiotic-associated diarrheas, and also this one with this meta-analysis, you can convince them. So in National Guard, at least if you have to make or cost-effective, as cost-effective, someone has admitted the gastroenteritis staying 5 days. So as cost-effective, you may convince this system that I'm going to use probiotics to decrease the cost effects. That's number one. Number two, insurance, I think no problems, especially if someone has frequent visiting to you in your clinic. Usually, if someone has frequent with abdominal pain or diarrhea, the insurance sometimes they have accepted with the probiotics approved, not every probiotics, like Lactobacillus reuteri in the colic. Yes, I didn't find any problems to use it in either insurance or others.
Other question here? Get the mic, please.
Assalamu alaikum. Shukran, Dr. Muhammad. What's your opinion about to add the probiotic in the infant formula?
There is no evidence, Badr. Again, to use the infant formula or the probiotics in breastfed in infantile colic. This is the only evidence shows. Others just only like retrospective studies, cohort studies, case control studies, but there is no RCT trials to use probiotics in infant formula.
Thank you, Dr. Muhammad. I'm Dr. Abdulaziz Harbi, pediatric gastro. I would like to ask you two questions. The first question about do you in your practice use the probiotic? Number two,
sorry,
do you use in your practice? Number two, about the acute gastroenteritis. Any more details about how long can I use? And how long can I use this probiotic and when? You know, in acute gastroenteritis, I can use it lactose-free, for example, and the patient will improve. As well, the probiotic, the same, maybe the improvement and during the, viral illness. Thank you.
Thank you, Dr. Abdulaziz. In my practice, I use it limited. What to limit it? In case of infantile colic, I give it to the mom for breastfed. Number two, maybe in diarrhea, I use it some of the strains, but not more than 7 days. So in the case of the infantile colic and diarrhea, regarding H. pylori, I didn't use it. H. pylori, I didn't use it for antibiotic-associated diarrhea. Usually, this comes with the pediatrician. They didn't refer to us. Second question, Abdulaziz. Gastroenteritis, yes, this is a big dilemma. I show you that it's not convincing, but I think with Dr. Maath at Turkey, we are a member board in the gastroenteritis guidelines. We are going to release gastroenteritis guidelines in all the kingdom or on MOH hospitals, and we conclude that to put it to advise it or not. So including zinc, probiotics, lactose-free. But in my practice, Abdulaziz, if you have antibiotic-associated diarrhea, use it. Nobody will argue. For gastroenteritis, still are conflicting data.
Thanks so much, Dr.
Thank you. Last question there.
Thanks so much, Dr. Muhammad, for this informative lecture. I have 2 questions. The first one is that you mentioned there are 2 common strains to be used as probiotics, the lactobacillus and the bifidus. What's the background of using these common 2 strains? And we know it in the practice also.
Yes. Yeah, this is one, as I show you, the most 2 organisms that are being studied, probiotics, is lactobacillus and bifidobacterium. And this is why now they implemented in NASU for high incidence of neck. So this is why I asked our colleague in NICU, neonatologist, they said, yes, we are ready to use it, especially if I think one of the private section in Riyadh, they use protocol for these 2 organisms. But again, Abdullah, we didn't know the dose. So usually it's different, the doses, different duration. And this is why we use it as precautions in the necrotizing enterocolitis. The others, you can use it for antibiotic-associated diarrhea. So you can use it. So again, at the end, I put it that you cannot use it as a routine practice because we need more data on it.
The second question, when we are prescribing the probiotic, it's commonly to be asked by the patient that what are the strain types to be buy from outside?
What's
the type of the probiotic to be used to buy it? Or any type we can prescribe it for them?
No, I will reserve this question, Abdullah. I will tell you in private. So, yeah, because, in private, I will tell you.
Okay, so thank you very much, Dr. Hassousa. We came to the end of the session. Please stay with us for the opening ceremony, and after that, we'll get a break. Please. Thank you.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه وسلم. نرحب بكم جميعا في المؤتمر الدولي السابع للجمعية السعودية لأمراض الجهاز الهضمي والكبد والتغذية لدى الأطفال. خير ما نبدأ به آيات من الذكر الحكيم.
مثل ذلك فإن أرادا فصالا عن تراض منهما وتشاور فلا جناح عليهما وإن أردتم أن تسترضعوا أولادكم فلا جناح عليكم إذا سلمتم ما آتيتم بالمعروف واتقوا الله واعلموا أن الله بما تعملون بصير.
صدق الله العظيم. والآن نستمع جميعا إلى السلام الملكي. كلمة رئيس الجمعية يلقيها الدكتور معاذ التريكي.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. بداية ننقل لكم اعتذار سعادة مدير الشؤون الصحية بمحافظة جدة الدكتور مشعل بن مسفر السيالي الذي كان مفترض أن يشرفنا اليوم، ولكن لظرف طارئ لم يستطع الحضور. كما تعلمون هذا المؤتمر برعاية كريمة من وزارة الصحة وبتشريف من سعادة مدير الشؤون الصحية بمحافظة جدة. أصحاب السعادة الزملاء والزميلات الكرام، السلام عليكم ورحمة الله وبركاته. نحييكم في مؤتمركم مؤتمر السابع الدولي السابع للجمعية السعودية لأمراض الجهاز الهضمي والكبد والتغذية لدى الأطفال والمعروفة بSASPGHAN, Saudi Society of Pediatric Gastroenterology, Hepatology and Nutrition. This is the fifth term for our society, الدورة الخامسة. خلال العام الماضي في السنة الأولى أقيم عدد من الأنشطة العلمية، كما تابعتم كثيرا من الأندية العلمية والمؤتمرات الدولية. كالمؤتمر الدولي لل IBD International, third IBD International Symposium. Now this is the seventh international for all the general gastroenterology and nutrition. طبعا نحن في الجمعية الهدف هو إقامة هذه الأنشطة وفق منظومة تقيمها الهيئة السعودية للاختصاصات الصحية، وتنويع المؤتمرات والأنشطة المجتمعية، وليست العبرة بالكثرة إنما بالتنوع والنوع الجديد. هذه هي متطلبات معايير الهيئة السعودية للاختصاصات الصحية. كذلك كما لاحظتم إعطاء الدماء الجديدة من أعضاء الجمعية الفرصة للمشاركة كمتحدثين أو مدراء جلسات أو حتى باحثين في هذا المؤتمر. والله الحمد لله أول مرة يقام ساتلايت سيمبوزيوم. البارحة بدأنا بالساتلايت سيمبوزيوم والليلة أيضا هناك ساتلايت سيمبوزيوم. يعني أشكر جهود حقيقة اللجنة المنظمة لهذا المؤتمر وجهود زملائنا في مجلس الإدارة، وكذلك الشكر موصول لكم جميعا أعضاء الجمعية والحضور ولمن يدعمون هذه الأنشطة. في هذا المؤتمر أيضا هناك مسابقة البحوث، يعني abstract tomorrow will be have يعني oral presentation. We selected the first three prizes and also the others will be also given tomorrow the prizes. ختاما أشكر لكم حضوركم، أشكر لكم تواجدكم. نحمد الله سبحانه وتعالى على إقامة مؤتمر حضوري بعد سنتين من الجائحة، سنتين من البعد، ونسأل الله سبحانه وتعالى أن يرفع هذه الجائحة عاجلا غير آجل. وحقيقة ما لمسناه البارح، يعني ليلة البارحة من أسمي الشعور الوجداني أو النفسي عند الزملاء يعني كان حقيقة جيد. يعني فكان يقول الزملاء والله العلم موجود في كل مكان، لكن احنا مشتاقين نشوف الزملاء، نسينا أشباههم، نسينا أسمائهم. فجزء من حقيقة من دور الجمعية جزء المجتمعي، الدور المجتمعي، اللقاء مع الزملاء، التعارف. ما شاء الله ويهاف ما شاء الله في السنوات الأخيرة مجموعة كبيرة ما شاء الله من الفلوس واللي ما شاء الله أصبحوا كونسلتنت وما نعرفهم صراحة، نحرج منهم يعني حقيقة. it's good حقيقة to يعني have social meetings, social gathering with each other, تعارف مع بعض، المستشفيات، نخدم بعض، نشاور بعض. Even from our colleague from outside يعني the kingdom, our colleague from Gulf يعني دكتور فواز مشكورا شاركنا حضوريا. الزملاء والزميلات الكرام في الكويت ودول الخليج العربي في الإمارات وعمان وقطر والبحرين, they are now sharing with us a virtual. Also our colleague from outside Saudi Arabia, we have received emails. They like to come to Saudi Arabia, making Umrah and attending that one. They ask to issue for them visa to attend, and it's one of the aim to put it حقيقة in Jeddah because Mecca is attracting, for people who like to performing Umrah. فنسأل الله تعالى التوفيق والسداد. نسأل الله تعالى أن يكون يعني أن ما قدمناه خالصا وجه الكريم. فإن أحسننا فمن الله وحده، وإن أخطأنا فمن أنفسنا والشيطان، وأرجو أن تحملوا أي تقصير، فنحن مجتهدون ونحن بشر وما على مجتهد من نصيب. مرة أخرى أشكر لكم جميعا حضوركم، أشكر الشركات الداعمة لنا حقيقة في هذا المؤتمر، جميع الشركات شكرا جزيلا. Thanks for all the companies who supporting really this big conference, and also extend my thanks to our colleague in Eurolink, who's event management company, who's sharing with us this year to conduct this event. مرة أخرى ألف شكر جميعا، ما قصرتوا، وشكرا دكتور إياد. تفضل.
شكرا دكتور معاذ. من أي أبواب التكريم بكم سندخل، وبأي أبواب القصيد نعبر، وفي كل لمسة من جودكم وأكفكم للمكرمات أسطر. لا يكتمل حفلنا إلا بتكريم من هو أهل للتكريم. أدعو الدكتور عبد الله الزبن والدكتور حربي شاوش لتكريم أولاً تكريم أصحاب المبادرات في نفس تخصص الجمعية. الدكتور بدر بن محمد السليم. الدكتور بدر استشاري أمراض الجهاز الهضمي والكبد والتغذية لدى الأطفال بمدينة الملك فهد الطبية بالرياض، حيث قام بإنشاء برنامج تأهيل فشل الأمعاء والتغذية الوريدية للأطفال المصابين بفشل الأمعاء الخلقي والمكتسب، وهو البرنامج الوحيد في المملكة العربية السعودية، حيث قام بتأسيس وحدات متخصصة بالمستشفيات الطرفية التابعة لوزارة الصحة لمتابعة خدمة علاج هؤلاء الأطفال في مناطقهم وعند أهلهم وذويهم. وترتب على هذا تدريب العديد من الكوادر الصحية من أطباء وصيادلة وممرضين على الطريقة الصحيحة لرعاية هؤلاء المرضى والاعتناء بالقسطرة الوريدية وطريقة إعداد وإعطاء التغذية الوريدية. الدكتور علي بن إبراهيم المهيدب. الدكتور علي استشاري ورئيس وحدة أمراض الجهاز الهضمي والكبد والتغذية عند الأطفال بمستشفى الملك فيصل التخصصي ومركز الأبحاث بالرياض، حيث قام بتأسيس برنامج الزمالة السعودية في التخصص، وتخرج على يديه أكثر من 43 طبيب وطبيبة في مختلف مناطق المملكة العربية السعودية ودول الخليج العربي. كما قام بتأسيس النادي العلمي للتخصص في المملكة العربية السعودية في شهر يناير 2008. ثانياً تكريم رؤساء الفروع ومشرفي الأندية العلمية. الدكتور حربي شاوش. الدكتور حربي المشرف على النادي العلمي بمنطقة مكة المكرمة ورئيس الفرع. الدكتور محمد تمران. الدكتور محمد التمران المشرف على النادي العلمي بمنطقة الرياض. الدكتور ماهر الهطلاني المشرف على النادي العلمي بالمنطقة الشرقية. الدكتور خالد الرحيلي المشرف على النادي العلمي بمنطقة المدينة المنورة. الدكتور عبد العزيز الحربي المشرف على النادي العلمي بمنطقة القصيم. الدكتور عبد الله الشنبلي المشرف على النادي العلمي بمنطقة مكة المكرمة. الدكتور عادل الشهراني المشرف على النادي العلمي بمنطقة عسير وجازان ونجران. تستاهلون.
ايضا نبغى نكرم تكريم الاساتذه الذين شاركوا في تحكيم الورقات العلميه. الاستاذ الدكتور احمد الصرخي كمحكم للورقات العلميه. طبعا يوم غد ان شاء الله سيكون هناك جوائز الفائزين بالورقات العلميه. الدكتور احمد الصرخي احد المحكمين للورقات العلميه. الدكتور خالد القعير كمحكم الورقات العلميه. والدكتوره رزان بدر اعتقد لسه ما وصلت، عندها ظرف تصل الليله ان شاء الله، هي معنا بكره ان شاء الله. معلش.
ثالثا جائزة خدمة الجمعية. داوبت الجمعية على تكريم المتميزين في خدمة الجمعية منذ إنشائها، حيث تم تكريم الدكتور محمد الموزان في عام 2018 والدكتور أسعد عسيري في عام 2019، واليوم يتم تكريم المتميزين لعام 2020 ولعام 2021. أولا المتميز لعام 2020 الدكتور علي المهيدب. المتميز لعام 2021 الدكتور معاذ التريكي. واخيرا ندعو الدكتور حربي شاووش لافتتاح المعرض، والدكتور عبد الله الزبن. ولكم جزيل الشكر.
Okay, should we start?
Am I allowed to start? Good morning, everybody.
Okay.
Assalamu alaikum. We're going to
Am I
start
allowed
the
to
next
start?
session.
Yes.
The first speaker is Dr. Merit Tivler from Amsterdam, Netherlands. She's highly rated in 6 conditions. According to the data, the top areas of expertise are chronic adiabatic constipation, reflux, and reflux disease, and microvillus inclusion disease. She has been co-authors for more than 115 reviewed articles for the last 15 years. Dr. Merit, she's gonna present for us today the management of infantile constipation, and it's gonna be online. Thank you.
Good morning, everybody. Thank you very much for your kind introduction. Do you see all slides, and can you hear me clearly from the Netherlands?
Yes, your sound is clear.
Great.
And you are online now. You can start, Prof.
Thank you so much.
You're
Thank
welcome.
you so much. Thank you for your help. Thank you for your kind introduction. I will talk today about the management of functional constipation in infants and toddlers. And my name is Mary Tabbers. I'm a pediatric gastroenterologist from Amsterdam, the Netherlands. This slide shows some pictures of our hospital, which is very colorful and very light. 2 big hospitals from the Netherlands became one. This is a map showing that the Netherlands are very small. We have 17 million inhabitants, and we are very famous because of our tulips, our cheese, our bicycles, and on the left side down under you can see our king and queen on the bike as well, and the right side under you can see Amsterdam with the small houses and the canals. I will give a short introduction. I start with a definition. We will discuss non-pharmacological treatment, and we will discuss pharmacological treatment, and I will end up with a summary. We know that in 70 to 40% of the children, constipation starts in the first year, and no organic cause can be identified in 95%, so that's really high. It is often associated with infrequent and/or painful defecation, fecal incontinence, but also abdominal pain. This causes significant distress to the child and the family, having a lower quality of life, but also a significant impact on healthcare costs because they are visiting your first aid and your outpatient clinic frequently. What about the etiology? We know it's multifactorial, but really not well understood. But we know there is a vicious circle of learned behavior. Toddlers are experiencing painful defecation, which will lead to a stool withholding behavior with as a consequence larger and harder stools, and again pain, and so on and so on. We do know that you have to verify proper formula preparation in infants. This slide shows you a prospective study from Italy, Belgium, and the Netherlands, and we have assessed in well baby clinics the prevalence of functional constipation in children up to 1 year, and this prevalence is 3%. For the toddlers from 1 to 2 years, the prevalence is 9.7% in these 3 countries. We also have performed a systematic review meta-analysis, including many studies, showing that the prevalence of functional constipation was 8.6 in boys and in girls 8.9, which was more or less the same. And we know that geographical location, dietary habits, and exposure to stressful life events were reported to be associated with a higher prevalence of functional constipation. This slide is nice because it was showing that we have included 35 studies on constipation, a lot of studies from Asia, as you can see, and 1 study from Saudi Arabia. So that's really nice. But what's the normal defecation frequency? What do we know? We do know that breastfed children have a higher defecation frequency compared to the formula-fed children, and the younger children have a higher defecation frequency compared to the older one. So breastfed children 0 to 3 months will have a defecation frequency of 2.9 per day as a mean, and formula-fed 2.0. And if you see children 1 to 3 years, it's like 1.4 defecation frequency per day, and older than 3 years, it's 1. How do we diagnose functional constipation? Do we need a lot of investigations? No, we have the Rome 4 criteria, diagnostic criteria, which are easy to apply in your outpatient clinic. It must include 1 month of at least 2 of the following in children or infants up to 4 years of age, 2 or fewer defecations per week, a history of excessive stool retention, a history of painful or hard bowel movements, history of large diameter stools, or the presence of a large fecal mass in the rectum. And if a child is toilet trained, the following criteria may be used, namely, at least 1 period per week of incontinence after being toilet trained, or a history of a large diameter stools that may obstruct the toilet, and no underlying medical disease. If you are talking about the consistency, it can be very informative to use the Bristol Stools chart so that parents and children can show you how the stool looks like. What about the treatment? We know current treatment exists, education, explain to the parents what's going on, why this is happening, discuss dietary advices, discuss toilet training if the child has a developmental age of 4 years, and start oral laxatives is if education, explanation, and dietary advices will not work. We also know, and you have to discuss that as well, that it can be a long-lasting problem. 50% of the children are successfully treated and off laxatives after 1 year. And you also have to discuss that 50% of the patients who are using laxatives will suffer from side effects such as flatulence, pain, bloating, diarrhea, nausea, but also bad taste. So the first step in treatment is explaining and demystifying the problem to the family. Use a diary, discuss prevalence, discuss the chronic character, but also discuss the diet. But what will you advise? There are a lot of things you can advise, but what about the evidence? We will start with fiber prebiotics, then we will discuss fluid, then cow's milk protein-free diet, then we will discuss the evidence concerning probiotics, and we will end with the formula, magnesium-enriched formula study. So let's discuss fiber prebiotics. We know prebiotics are fermentable fibers, so we can discuss them here. And you can see here on this slide a summary of all the RCTs, 5 RCTs, including 370 studies. The quality of studies is very low to moderate. You can see the different outcomes, and you can see the effect. And you can see that most of the fiber studies are showing no significant differences. Here I show you a forest plot. Above you can find the comparison with the outcome measure treatment success. And then you can see we have included 2 studies investigating glucomannan versus placebo. So a meta-analysis was only possible in 2 studies, showing no effect. And the second one is concerning the outcome measure defecation frequency. And again, extra fiber is showing no effect in this study. Of course, keep in mind that there are a lot of studies showing that children suffering from constipation have mostly of the time a too low normal fiber intake. So you have to discuss diet. You have to discuss that they have to take a normal fiber diet, but extra fiber is not necessary. It's not working. Then let's discuss fluid. What about fluid? There's only one very bad design RCT, including 108 children, but I want to discuss it with you just to show you that there's only one study with an unclear definition of constipation, consisting of 3 groups. Group 1 was receiving 50% increase in water intake. Group 2 was receiving hyperosmolar supplemental fluid, and group 4 was receiving a normal fluid intake. And the stool frequency at 3 weeks was all the same in the 3 groups. So what do we recommend based on the SASPGHAN and NASPGHAN guideline, which we hope to update soon? 1, a normal fiber intake recommended in children with constipation. With or without any other disease, children need a normal fiber intake. And based on expert opinion, we recommend a normal fluid intake in children with constipation according to their age and weight. And that's the same with or without constipation, you have to have a normal fluid intake. So what about a cow's milk free diet? That's really a difficult issue also. There are several studies, 5, but they are having conflicting results. I will show you 2 studies which were performed in an allergy clinic. So you have bias because of the included patients. And then you can see favor using cow's milk exclusion diet with respect to the outcome treatment success. But all the other studies didn't show any effect. So what did we say, what did we recommend? We recommend, based on expert opinion, a 2 to 4 weeks trial of avoidance of cow's milk protein may be indicated in a child with intractable constipation, defined as not responding to optimal conventional treatment for at least 3 months. And please, I have to emphasize that, of course, breast milk is the best there is. So you have to discuss with parents if it's really needed. And you see here a flow chart from our guideline. And at the end, you can see it in the red circle. You can consider to start a hypoallergenic food after all other treatment was not successful. And this is for children only under the 6 months of age. What about probiotics? There are many probiotics. Everybody is using probiotics. It should be very helpful, but what about the evidence? But first of all, I want to discuss the hypothesis, how will it work? We know that probiotics enhance peristalsis of the colon by producing acid and consequently decrease the colonic transit time. And they can also soften the stools by stimulating water and electrolyte secretion. This is a summary of 6 RCTs concerning constipation, including almost 500 children. And in red, it will say not effective. In green, it will be effective. The 2 studies in green are of very low quality, and some studies in red were of moderate quality. But you can see there are different strains used, different dosages, and in general, it's not working. You can see the treatment success because we have performed a meta-analysis again. It was possible for some strains. And then you can see that per strain, there was no significant effect concerning the outcome measure treatment success. And concerning defecation frequency, a meta-analysis was possible for 2 studies showing no effect. So the routine use of probiotics is not recommended in the treatment of childhood constipation. And of course, parents sometimes want to try something or don't want medication So I always discuss the evidence and always said, okay, if you want to try, please use it for 2 weeks and take into account good outcome measures. And if it's not working after 2 weeks, so if it's not softening the stool or the constipation will not be resolved, please stop it again, because it's expensive as well. And to understand the studies and the conclusion, we also have to taking into account that there are all small sample sizes and the quality of the studies is low to very low. Different strains were used, different dosages, heterogeneous patient populations, different effects. And also we discuss about the microbiome, which will be different across the world in different groups. So it should be a more tailor-made management in future. So what can we offer concerning the diet? It's difficult. But there is one study, magnesium-enriched formula, the Novolac IT versus comfort-based formula study. It was a randomized controlled trial. Unfortunately, not blinded, but this is the only study there is, and I want to discuss with you because they have looked at improving the stool consistency and the frequency in constipated infants. Novolac is consisting of 100% of lactose versus low lactose in the control group. It's consisting of whey and the control group partially hydrolyzed whey. It's containing high magnesium versus low magnesium, and it didn't has prebiotics, but the control group has HOS and FOS in the formula. What do we know about the increase in magnesium intake? It will improve stool consistency in children, and magnesium will lead to more expression of the aquaporine-free water channel, which will lead to more water finally in the feces. And we know that constipation is associated with the low dietary intake of magnesium, fiber as well, but magnesium also. And what do we know about lactose? Because there was 100% of lactose in the formula, in the intervention group. It's unique in the high sugar content, 70 grams per liter lactose, which is 40% of the caloric value. So it's an energy source, an important one, providing glucose and galactose, which is very important for different macromolecules. And it has also a microbiota modulating effect of indigested lactose into the small bowel, from the small bowel to finally the colon. But avoiding lactose containing products, you also have to keep in mind that a lower intake will also have can cause a lower intake of important nutrients and deficiencies such as calcium. So we know that lactase on the surface of the small bowel will divide lactose in glucose and galactose. And if that's not working, you can have bacterial fermentation, production of Cas and acids, leading to complaints such as flatulence, diarrhea, abdominal pain. So this is the study from your region, including 15 sites. So that is really amazing. It's an open label randomized study from 2016 to 2017. Children with functional constipation according to the Rome 4 criteria were included and they were of age 6 months or less. 286 children were included, 143 received the magnesium-rich formula for 30 days, and 142 received the control formula, and all children were taken into the intention to treat analysis. So I discussed with you already the inclusion criteria. Exclusion criteria were as follows: exclusively breastfed or mixed-fed infants, infants diagnosed with an organic cause of constipation, children under laxative treatment, infants with known cow's milk allergy or any other allergy, and anemic infants taking oral iron supplements. What about the data collection? The physician was ready and saw the patients during 3 visits, day 0, day 8, and day 30. And the parents used diaries. So they kept their own diaries. and they did it from day 1 to 7 and day 23 to 29. So the primary outcomes were improved stool consistency and increased frequency. And you can see on this slide that a normal stool consistency was achieved day 23-29 in almost 96% of the magnesium-rich formula versus 6.5 in the control formula, which was significantly different. And also for the stool frequency, having no stool frequency was only 1% in the magnesium-rich formula group versus 7 in the control formula group, and having a stool frequency of 3 was 26 in the intervention group versus 7% in the control group, which was also significantly different. What about the secondary outcomes? Complete responders to treatment. At day 29, 36 in the intervention group, 26%, versus 5 in the control group, counting for almost 4%. So that was a difference, which was also significantly different. And parent satisfaction was really high, 81% in the magnesium-rich formula group versus 10 at day 29 in the control formula group. This slide shows you on the vertical axis the mean pain score, and on the horizontal axis the days. And you can see easily the orange one is the magnesium-rich formula, and the control group is in yellow. And you see that the mean pain score is lower in the magnesium-rich formula during the first week. So what about the pharmacological treatment? Because if explaining and if dietary advisors and toilet training in the older child will not be sufficient, you have to continue with pharmacological treatment. So the use of PEG, polyethylene glycol with or without electrolytes, is recommended as first-line maintenance treatment. However, lactulose is more or less even effective. So if PEG is not available, you can use lactulose, of course. A starting dose of the PEG should be 0.4 grams per kilo per day, and the dose should be adjusted according to the clinical response. The addition of enemas to the chronic use of PEG is not recommended in children with constipation. There is one study concerning fecal disimpaction showing that oral laxatives or enemas are equally effective. Only the oral way is, of course, the mode of administration preferable for a child. So that's why the oral laxatives are recommended. You have to explain to parents that the bowel will not be lazy by using PEG. It will only make the stool softer. That's very important because parents are always afraid that the bowel will become lazy. PEG is very well tested in different studies, so it's safe to use. And based on expert opinion, the use of milk of magnesia, mineral oil, and stimulant laxatives may be considered as additional or second-line treatment. What about the duration? There are no RCTs, but based on expert opinion, maintenance therapy should continue for at least 2 months. So you have to discuss with parents, because many parents are thinking if it's resolved in 1 week that it's done, but it is a long-lasting problem. So all symptoms should be resolved for at least 1 month before you are going to decrease the treatment, and you should do that gradually. So this is a pyramid showing the treatment of constipation, also for very rare cases. But you see below that there is conservative and medical methods, including lifestyle, diet, exercise for the older children, education, toilet training, and laxatives. And in the older children, sometimes cognitive behavioral therapy or biofeedback. If it's not working, then you have to go to the transanal irrigation. It's rare, but it exists. And sometimes you have to go up in the pyramid and consulting a surgeon as well. But again, very, very rare. So the treatment, in summary, explain, demystify the problem to the family, use a diary, discuss the diet like we have done a few minutes ago, and start the maintenance therapy if still constipated, and evaluate, very important, evaluate how it's going. What about the prognosis? Also important to keep in mind, also when you are explaining and having the first consultation with the child, that among the patients referred to pediatric gastroenterologists, 50% will recover and we will out laxatives after 6 to 12 months. So that's quite long. Approximately an additional 10% are well while taking still laxatives, and 40% will be symptomatic despite the use of laxatives. And we know that respectively 50 and 80% of the children are recovered after 5 and 10 years, with the vast majority of patients no longer taking laxatives. So we have performed the study. It's a time ago, but we have repeated, and it's quite amazing how long-lasting the problem is. And still concerning this problem, people are ashamed, don't talk easily about it, but it's really a huge problem. So we have to keep in mind the prevalence, which is really high. You can see on the horizontal axis the time of follow-up in years, and the vertical axis is showing the percentage of children. The blue bar is for children with no success, but with laxatives. The green bar shows no success without laxatives. The yellow bar is showing success with laxatives, and the red one is showing success without laxatives. And you can see here, after 15 years, in this study, everybody was okay. So in summary, functional constipation defined by Rome 4 criteria. Prevalence 9%. In 70 to 40%, it starts already in the first year. Treatment exists of education, diet, toilet training, and if no effect, start oral laxatives. A normal fiber and fluid intake is recommended. A 2 to 4 weeks trial of avoidance of cow's milk protein may be indicated in a child with intractable constipation. And the routine use of pre and probiotics is not recommended. And the children have a lower quality of life. So it can be a long road, constipation. I will thank you all for the attention, and I would like to thank again the organization for inviting me, and I wish you pleasure with the Congress. Thank you very much. This was my presentation.
Thank you so much for your lecture. It was excellent and informative. We're going to open the session for any questions. Somebody will give her the mic.
Good morning, Prof. Thank you very much for this presentation. I just have a question about the weaning of the medications. If a patient with functional constipation start responding well to my medication, what's the duration shall I wean the medication for? Like months or weeks?
Thank you very much for your questions. Really important question, because we're always struggling with this. I think if you can discuss with parents, we said in the guideline 2 months, but I think we can do, if it's going for 1 month, it's going fine, and you see nice prognostic factors, and the parents are doing fine. I would say within 2 to 4 weeks would be perfect. But we have to discuss that there is a chance of relapsing as well, and then they have to increase it. So I would suggest 2 to 4 weeks.
Thank you, Prof, for this interesting lecture. Just the debates about stimulant use, for how long? As we know that stimulant use usually it's restricted for a few days. Some of the physicians, if they struggle with the laxative that didn't work, they will use it for longer time, even sometimes months, or even maybe a year or more. What's your opinion about that?
So much is again also a very important question, because there are hardly no studies concerning this problem. In general, if a child is on oral laxatives which will be not efficient, sometimes I add bisocodyl, for instance, And then I said, okay, if there is no defecation for 3 days, add the bicycodil daily until there is defecation. So, and then you have to stop the bicycodil. That's how I do it in practice. But some children are doing it better on only bicycodil. So then I use it daily. So that's my answer. But we are not sure it's safe for the long time. So I think the message should be try to use the PEG or the lactulose and the enemas if necessary. And if that's not working, please add the bicycodil, but try to limit that. That's the only thing I can say. And that's based on adult literature, you know, but I have some children, I have to say, who use only the bicycodil drops, for instance.
Thank you.
Thank you for this interesting lecture. Regarding this use of juice like prune juice for infants less than 6 months.
Sorry, what was your question? I didn't hear it well.
Like the use of juices like prune juice.
Ah, juices, yeah. Thank you. This is also really nice. We have performed a dietary systematic review, and everything is conflicting. So I didn't find any evidence to say that's good or bad, but in general, sugar will be nice for the stools, but we only know in adults that coffee, for instance, will have as a consequence a better consistency. But for children, I cannot clearly answer because we don't know. So I don't advise juice because there is no evidence that that will work. But I think we also have to look at the child. It's an individual, and the microbiota, we have to learn more about that because that's also different across the world. So the dietary management could be important. The only thing we can say, normal fiber, normal water. But sometimes parents are telling me after juice his stool is much better. Okay, so then I'm happy, you know. So it's tailor-made.
Thank you, Prof, for your perfect lecture. I want to ask about the usage of the ready-to-use high fiber solution as a replacement of dietary fiber, especially in picky eater toddlers.
Thank you so much. So if I understand your question well, you was asking me for the ready-to-use high fiber product. Is that true?
Yes, a high fiber solution which is available in the market.
Yeah.
Used as a replacement of dietary fibers.
I think if a dietitian can count the fiber intake of the child and it's too low, it should be 5 grams per age, 5 grams plus the age of the child, then you can, then if it's not sufficient, then that could be a good opportunity. So the answer, yes, if the child is not eating well, then you can take that.
Thank you.
If they like it, because that is most often a problem. They don't like the extra fiber.
Okay. Thank you, Dr. Aminat. Thank you, Dr. Sharifa. Thanks the organized committee to invite. I'm Dr. Yasser Soufi, pediatric gastroenterology at King Saud Hospital, Qasim Unaiza. Also, my pleasure to introduce the next GI functional disorder, our senior consultant, Dr. Mohammed Hassousa, to just discuss about intractable childhood constipation. Welcome, Dr. Mohammed.
Thank you, Dr. Yasser. And I would like to thank the scientific committees, SASPGHAN, for this invitation. My lecture is different from Dr. Taber's that for chronic refractory constipation. So I'm going to talk about some data on Saudi Arabia constipation. So we will focus on the refractory constipation, what's the prevalence and what's the causes and what's the management. And we know that it is common that you see the constipation up to 3% general pediatric, while in pediatric gastroenterology up to 25%. And this is, I can skip this slide because they will describe about the wrong 4 criteria. We should know that chronic constipation differ from other functional disorders, that the national history of the functional constipation extend up to the adulthood. So this is one of the most important to explain how these constipation behave comparing to the other functional disorders. Regarding the prevalence, if we see the prevalence of the constipation is variables. Why? Because they didn't apply wrong criteria, heterogeneities. In the United States, up to 10%, in Brazil, 20%, in East Asia, around 20 to 30%, in Saudi Arabia, in adult up to 11%, while in pediatric, 32%. I found 2 recent studies by Dr. Al-Hassan and screened around 500 patients. They found the prevalence up to 4%, while Dr. Ammar, he found that up to 4.7%. But in our data, we screened about 9,000 school children. And we found that most of them, or 32, they are constipated. And the older age, more than 10 are more constipated, and the girls are more constipated than boys, behaving like IBS symptoms. So we are still conducting studies now. We are collecting data on behalf of pediatric gastroenterologists, Dr. Mehedib, Dr. Sarkhi, Dr. Al-Gair, Dr. Najat, Dr. Adil, and we did still collecting this data to find what's the common functional GI disorders. And the preliminary result, we are not surprising that constipation is account up to 25% comparing the controls. And we found the second functional GI disorders, it is regurg. Then the least is eryphagia and dyschezia. And hopefully, inshallah, within the next few months, it will be released for final result. Regarding the definition of chronic refractory constipation, it is defined as that the child is unable to pass stool in the spite of the maximum treatment on the daily rectal stimulation and enema for more than 3 months. Until now, it's not clear. Why? Because they didn't clarify which medication. We don't know which medication to have maximum. They didn't clarify what's the maximum dose, still not clear. And according to the prevalence in the tertiaries, it is almost or 20 to 30%, but in the tertiary centers usually is uncommon. And the children who are not responding to the laxative, usually they are struggling from fecal incontinence, from the impaction, from failure to thrive, from rectal prolapse, and etc. So this is why we need to understand that constipation has been synchronized between pubis rectalis and external anus sphincters. And this is why in this synergic obstruction, they have disorganized between pubis rectalis and external anal fissure in spite of the normal or abnormal rectal pressure. In addition to that, so we need to break these cycles because the child will have pain and will have holding and will have all of this. To make it more clear that in refractory constipation is not only the GI risk factors, including microbiota, dysmotilities, and even the sinus factors through the afferent, through the depression, through the stressful, through the anxieties. So has been worked and studied exclusively for refractory constipation. And in the same studies, we found those children that who is skip breakfast and skips or have school phobia and night sleeping less than 7 hours, and they are doing homework more than 3 hours per day, are more prone to constipation. So again, we need more data or prospective studies to explain these risk factors, why they are constipated more than the others. Well, the question or the most important that most of the current constipation, especially refractory, presented with the diarrhea. So this is why is the rectal examination is must. So because this incontinence or urine incontinence associated with refractory constipation. But look to this comparable. The SASPGHAN and SASPGHAN said rectal examination is not always recommended for diagnosis of constipation. While in Rome 3 and 4, they said presence of the fecal mass is the criterion for constipation. So we have different opinion. So in this way, we applied cross-sectional studies in GBN, and we found that unfortunately, 40% of the pediatrician and pediatric gastroenterologist, they're doing rectal examination. So this is very low number. So we didn't know why they are not doing rectal examination, and despite a few documented there's a fecal impacting in the stool. And we asked the pediatrician, when you have refractory constipation, what's your response? 40 them, they refer to pediatric gastroenterology, which is good response because they didn't have more facilities. So good answer, they refer to us. While 10% they maximize the dose, 22 they change the laxative, and I don't know why they encourage fibers, almost 20%. Even in my experience, fibers has no rules in refractory constipation. And I'm surprising they refer for surgery, even most of them that are not Hirschsprung disease. So at least we have idea about our pediatric provider, what are doing when facing refractory constipation. So refractory constipation, why pediatricians struggle? The most important is inadequate dose. They use it as randomly, so they didn't use more than or ml per kg. Second possibility, ignoring maintenance treatment. They give just only short times for refractory constipation, and lack follow-up. And the most important, they underestimate the causes of refractory constipation. Recently, we published a review about what's the causes of refractory constipation. I make it more simple in 10 C's. Celiac disease account for refractory constipation. Cow milk account up to 10%. Cystic fibrosis and high calcium. So this is the common for refractory constipation, in addition to the top of the Hirschsprung disease. While others like cord abnormalities like spinal cord, bronchitis, colorectal, connective tissue disease are not common and extremely common or extremely rare to see as refractory constipation. And the most important that I want to address is the slow transit constipation. So what is slow transit constipation? Slow transit constipation, the child will present with a soft stool, not hard stool. So it will confuse the pediatrician that the child has normal stool. Sometimes the fibers make the stool or constipation worse. And they have, or the majority, 90%, they have no fecal mass in the rectal or rectosigmoid. So make it more complex that Rome criteria, they found that you should have rectal mass. So again, how to confirm it? By colonic transit test. So the colonic transit studies, sorry. The colonic transit studies, this is the marker studies. It was available in National Guard, but nowadays it's not available because it's time consuming. It is one of the most important parameters to assess the severity of the constipation. Usually it will differentiate this is motilities or this is a gastric or outlet obstruction. And usually if the delayed or the CTT more than 100, it means that it's an neurodysplasia or post-Hirschsprung, and it will tell you to predict the prognosis of the constipation. And this is the symbol. This is the markers distributed all around the colon. It means it has slow transit constipation. While if it is accumulated at the rectum, this is, we call it dyssynergic obstruction or outlet functional obstruction. Why I know? Because different management. In slow transit medication, you need to use colonic specific medication or prokinetics like lopiprostone and procloramide. Even there is a new by Dr. Beringa found that small RCT trials have been helped lobistrone in functional or refractory constipation, while in the functional or dysenergic, you need biofeedback to restore the normal pattern of defecation. Unfortunately, we didn't have good experience pediatric psychiatry for this biofeedback, which is very, very helpful in Saudi population. So Beringa found that the slow transit account up to 20%, while gastric outlet obstruction account for 20%, and most of them, they have non-retentive fecal incontinence. So this is why in management, usually is deeply difficult to manage. So this is why it will give you clue, most of them are not responding well, and fibers will be contraindicated because the motility is slow, and it's being used or in pediatrics, small numbers, but still not recommended, that you use colonic specific prokinetics like procalobride or chloride channel activator like lopestrone, and the most important effective is antigrade continence enema. So this is the modalities to use constipation as anorectals, sigmoid, upper GI, and this is one of my patients that he has refractory constipation and typically has dilated colon with transitional tend to the Hirschsprung disease. So the best approach to see in refractory constipation usually will start first line osmotic laxative. And this is the meta-analysis for BEC 3350. It's shown that it is effective in the reduction of the stool, but there's no data on BEC 3350 in refractory constipation. So at least we have some element of this one. If not responding, we maximize the dose. Sometimes we add stimulant like bisacodyl or sodium bicosulfate and try to categorize what the type of the constipation is, a slow transient or it is obstructed. Then we try to categorize which one will be response, either the prokinetics or colchicine, which is all medication. Sometimes we use biofeedback. And the most important and the last thing is surgical strategy. Usually surgical strategy, I reserve it at the end because it may add damage to malfunction intestine. So if you have good experienced centers or good surgeon, you may do it. So this is why when you choose your patient, do he need medical or surgical, the most important thing that to do colonic manometries. So if there is absence or disabilities of the high amplitude propagating contraction, it means there is no doubt to start or to put cecostomy. So ACE, antigrade continence enema, I think I've seen a lot of, or some of center they do it. And this is the best data showing that screen for almost 200 patients and the median age up to 5 years. And most of them, they are 60 per day due to refractory constipation. And they have good result up to 93%. And usually the soiling, which is very important, improving in 75%. And the symptoms resolve or no more antigrade. If you compare it or if you see the sacral neurostimulation with the chronic refractory constipation, you will see the baseline will be increased, the stool from 6 to 17 per days after 3 weeks of the treatment. However, the abdominal pain and scrumming and all of these will be helped. But if you compare which one, sacral stimulation better or ACE, both of them have better durable treatment. However, sacral will help in fecal incontinence, while antigrade help in the refractory constipation. So again, this is the only studies in pediatrics show the compare between antigrade enemas and sacral neurostimulation. There is a not recommended SASPGHAN to use transabdominal rectal ultrasound because they found that the cut level between 30 millimeter between the healthy and children was not overlap. So they didn't use these modalities of investigation. And very invasive, one of the surgical invasives for rectal myomectomies. And even they said it is simple or effectively selected in chronic refractory constipation, we need a good surgeon or colorectal surgeon to help this one. Even there has been all of these to have which diseases have refractory constipation and been effective for these myomectomies. The last thing is the intrasphincteric botox, and the only RCT in pediatric these studies, and they found that the painful stools reduced from 88 to 15%, comparing the control was reduced from 90 to 86. And even though the stool was hard and reduced from 80 to 28 after botox, and finally, which is very important, that the soiling is decreased up to 8% after botox injection. So now we'll come to conclusion or the summary of the algorithm for the constipation. As usual, when there is no red flag, we give a treatment, laxative. Depends on your experience. If you are experienced lactulose, use lactulose. If you are experienced big, use with big. So, but the most thing was the drug of choice is big, 350. And usually I maintain up to 4 to 6 months, usually maximum 4 months. If relapse, I re-educate, adherence, and different medication I use, and I will wean over 3 months. What's happened if it's the relapse? Usually you need pediatric gastro. We need to screen for celiac. We need to screen for thyroid is indicated, and sometimes calcium level. And usually we maximize treatment, and we'll give a trials of hypoallergic if the child is less than 1, and we'll do barium. If abnormal, most likely hairspring, and we refer to surgery. So what's happened if the barium edema is normal and the patient is soiling? Unfortunately, if you have good centers for biofeedback and behavioral and no response, usually you need anorectal manometry and balloon explosion test. And even in adult GI, I ask them, only limited gastroenterologists, they're doing these modalities. And we need to improve, and we need to encourage the fellows to more specialize in these issues. Why? Because if it's abnormal, this may mean that he has need to have to do defocography and he need biofeedback. So this is why we skip to transit times, because here, if it is treated with some bronchitis and no response, this is we call it slow transit constipation. And in this situation, we should give bronchitis with the newest medication, sometimes colostomy, and sometimes lobe ileostomies based on your experience. So I think this is a summaries for refractory constipation once you start at the beginning and what is the end. And the end, if you fail, make sure there is no spinal cyst by MRI of the spine. And sometimes I address a surgeon to do full thickness biopsies by laparoscopy and sacral simulation and intensive psychotherapies. So this is as make it more to understand how this refractory constipation comes. And in National Guard, we have regimen, we have pathway, we distribute it to the all primary care centers to say where you stop, and we ask them when you failed double dose of the maintenance, refer to the pediatric gastroenterology. Ladies and gentlemen, my conclusion is that prevalence of chronic constipation is up to 20%. In refractory constipation, consider motility disorders, stool expulsion, internal anal echinacea. I skip it because it's a little bit difficult, and post-Hirschsprung disease. Rectal examination is recommended for constipation and stool incontinence. So usually, mainly for stool incontinence, better to do stool examination. And slow transit constipation is suspected that the feces are soft rather than hard, and high fibers make it worse, and there is a global delay in the colonic transit times. Special imaging, it helps in refractory constipation, but the availability here is the barium enema and colonic transit times, which help in refractory constipation. Both integrate enema and sacral stimulation have durable improvement in children with a functional constipation and functional incontinence, and injection of the Botox to the sphincters is safe and effective. And if anyone is more interested, This is the 2 review articles from the adult and from the pediatric for extensive review about refractory constipation. At the end, I would like to enjoy my lecture. Thank you.
Thank you so much, Dr. Muhammad. You finish on time, and no, we have now question. Very nice and condensed lecture. As you know, the constipation is not always simple. We actually diagnosis and management, we have some challenge. So question time, please, before we go to the last session.
Assalamu alaikum. Thank you, Dr. Muhammad, for this thorough presentation. I have only one question. Have you have any experience in the usage of senna as a herbal medication as a second-line treatment for the pediatric constipation? Senna Makki.
Yes.
And at what age should we start this medication by your experience?
Yes, I think there is a new data in GBN that it is safe to use Senecot for long term, because we usually use Senecot for short period. We didn't make it more than 7 days. But according to the new data, we have been used, but in my experience, I didn't use Senecot. I use, no, not mineral oils, bisocodile. I use with Dulcolax. But Senecot, yes, you can use it. But as I said, everyone has good experience in his medication. But the new data that it is being used for long times.
Thank you, Dr. Muhammad. Again, I think one of the important points that we face in our practice that patients referred to the GI clinic with the refractory constipation, in the majority they were sent for barium enema, and almost all of them are normal. So what is your advice in regard to doing the barium enema in general pediatric practice?
Usually in barium enema, we don't want to clear or to make the stool empty. You should do the barium enema while the child is in backed stools, because if the pediatrician clear or give fluid enema and do barium enema, you will give false negative. So again, Dr. Ali, even the barium enemas, if you have good pediatric cardiologist, especially for ultra short segment Hirschsprung disease, at the end, usually once you suspect Hirschsprung, ask the surgeon for full thickness or for rectal suction biopsy. But the advice for barium enema, the child is not being bowel prep, so they should have it.
Thank you, Mohammed, for your nice presentation. I found in my practice that the usual failure of management of chronic constipation and reach to refractory constipation is the patient, they don't take the medication. And is it because of the taste sometimes, or because of duration of treatment? Because some of them, they don't like to use treatment for a long time. And I found the taste, especially the pig, is a little bit salty. So they don't like it, and they don't continue the medications. So do you think the other or combination, starting with combination and be aggressive of management of constipation from the beginning, that will decrease and minimize the refractory constipation in the future?
Yeah, I agree with you, Harbi. So in my practice, I ask them to dissolve it in توت. فهمتوا حق رمضان هذا. يعني I found it's dissolve. Even I discourage for these juices, but this is number one. Number two, there is X medication, big 350, not taste, not odors. I asked them to bring it from the USA. So it is kind of the big 350, no electrolyte, not taste, not odor, has been effective in those compliance to the medication. It's very effective. I agree with you.
Thank you, Dr. Muhammad. We have a 12 years old girl, case of, she's very keen, very intelligent. The problem is that she have intractable constipation with incontinence secondary to meningocele. We used everything, the frequent enemas, strong laxative, but we cannot control it at all. So what's your recommendation to us?
If you see the tendencies, because I have limited times, I explain about these colorectals and these spinal defects, which account about 2 to 5%. The best thing for them is the secostomy. Abdullah. Medication, yes, it may help, but usually there's because I didn't mention it, and the literature refuse, most of them, they respond for antegrade secostomy. Yes, try Botox, but I don't know who's experienced in Botox. I don't know. Huh? You are? Are you okay? Because we didn't have long-term effect. If you see these surgery strategies, the best data for long-term, it is the ACA enemas. So for Botox and others, so it will be limited.
Thank you, Dr. Hassousi. This is very informative lecture. I have just one comment and 2 questions.
Okay.
The SASPGHAN drug, I think this is very good medication for patients who have cerebral palsy. It's really useful for cerebral palsy patients. This is one comment. One question is regarding your comment about rectal examination. This is one of the unpleasant examination.
Okay.
How many patients you reach to diagnosis by just rectal examination? I think this is very rare.
Yeah, good questions. I mean, usually in obese child, not cooperative or sexual abuse, you may do abdominal X-ray, okay? But usually I recommend it for fecal incontinence. For if someone has fecal incontinence, it will assess how the severity of this one. And believe me, if the patient came to you as gastroenterologist, he's skipping around all pediatrician and nobody did rectal examination.
Right.
So I think we prefer just at once to make sure how this impaction, because maybe in addition to that, you may need this fleet enema for 2 or 3 days. Some of them, they need 1 day. So at least rectal examination, at least, yes, it's unpleasant, but it's a part of the GI examination.
Okay, second question is that what's your experience for the small babies? What is the best medication for constipated babies below 1 year?
Lactulose. I use lactulose. There is growing data that pig can use in 4 months, but no until safeties. You can use it after 6 months. But in babies, I use lactulose. Lactulose, 1 ml per kg.
Thank you.
Thank you so much. We know hot topic actually. Lots of question. Thank you, Dr. Muhammad. Have a good day. So now we'll go to the next session, please. Dr. Muhammad.
Assalamu alaikum warahmatullahi wabarakatuh. I'm Dr. Khalid Al-Gair, pediatric gastroenterologist at King Salman Armed Forces Hospital up north in Tabuk. First of all, I'd like to thank the SASPGHAN for the warm invitation and to give me this opportunity to meet you and to be in this place. And also to introduce our speaker for the next lecture. Our speaker is Dr. Alistair Baker from King's College, London. Dr. Baker has graduated from the medical school in 1980 and obtained his MRCP in 1986, FRCP in 1996. He has many national and international rules, as well as really well respected research work. He has published more than 120 peer-reviewed papers and many books, chapters, and he's really well known in the field of pediatric hepatology. So without any more delay, I'd like to welcome Dr. Baker. He will talk to us about a very interesting topic about Alagille syndrome, genetic versus clinical diagnosis. Dr. Baker.
Hi. Will they put me into the...
Can you unmute yourself, Dr. Baker?
How do I do that?
Yeah, no sounds, Dr. Baker. Can you unmute yourself, please?
I'm trying.
Excellent, excellent. We can hear you now.
You can. Okay, that's good. So you can see me. Yep. Okay.
Yes. Can you share your screen, please?
I will share my screen.
Yeah.
Right. Can you all see that? Is that okay?
Yes.
And you can hear me, so that's good. Right. So first of all, I would like to thank Professor Al-Mehadi for the invitation to take part in this conference and the scientific committee, and I'm delighted to be involved. It's a real pleasure. What I'd like to do during the next 30 minutes is to review the current management of aspects of Alagille syndrome, the one which are most problematic, I think, and look towards developing aspects for the future, particularly around transition as this group of patients gets older and goes on to adult services. I hope to show you in doing that our understanding of Alagille syndrome is evolving all the time, and that the adult survivors of Alagille syndrome and even some new diagnoses later in childhood and even as adults have a rather different type of disease to what's generally thought of as being Alagille syndrome, certainly in pediatric hepatology. So I remind you, because I'm sure that you're familiar with it, that Alagille syndrome has a classical definition based on its major features, with right-sided heart lesions, embryotoxin, and I'll show you that, vertebral anomalies, facial features, and cholestasis with paucity of interlobular bile ducts. And there are minor features which are recognized: short stature, delayed puberty, high-pitched voice. Nephropathy is becoming more to the fore as closer to a major feature than a minor one. Short radii, hypercholesterolemia as part of the cholestasis, and latterly bleeding and strokes. So you'll probably be familiar with these features and maybe have seen them from time to time. It's not a common disease, but it's very significant when we see it. It's quite problematic. And here is an example just to remind you of what patients with Alagille syndrome tend to look like classically. Here is a boy of about 5 years of age. He's short. You can see that he's jaundiced. You can see that he's scratching furiously. And you can see that he has xanthomas, cholesterol deposits throughout his legs, right up to his thighs, and round his body as well. As I say, his facial features are characteristic with the triangular faces, the rather snub nose or blunt-ended nose, deep-set eyes, and a pointed chin. Now, Alagille syndrome was technically originally described by Miller and Watson in the UK in Manchester in 1973, but they didn't recognize its full features and they didn't develop it further. About the same time in 1973, Alagille was publishing in the French literature, but published for the first time in the English written literature in 1975, and described cholestasis with 3 syndromic features as being diagnostic of what they called for the first time Alagille syndrome. Subsequently, renal anomalies have been included from Alagille's big series, and it's reckoned that based on this kind of diagnostic criteria, it occurs in 1 in 30,000 to 40,000 births in those populations where people have looked, although that's not universally the case. Latterly, we've changed that because we've had the availability of genetics, and now we would say, and I'll touch on this in a table in a moment, that if there's an affected family member and shared jagged 1 or 2, not 2 abnormalities, one must be suspicious of Alagille syndrome. And the reasons I think one must think about this is because symptoms do develop even in adulthood. And I'll come back to that at the end, I hope. So here's another example. In the top right-hand corner, I wanted to show you what embryotoxin is, or Axenfeld's anomaly, or Arcus juvenalis. And you can see it around the edge of the cornea. There is a line outside which the cornea appears slightly different. And it's a developmental abnormality. And it's seen in about up to 15% of the normal population, but it's almost universal. Over 90% of Alagille patients have at least one eye with some embryotoxin in it. And at the bottom on the left, you can see another example of a baby who is clearly jaundiced, but doesn't particularly have the facial features of Alagille syndrome, but the mother who does have the adult features of Alagille syndrome with the triangular faces, the pointed chin, the bulbous tip to the nose, and the nose more or less in the same plane as the forehead. Now, since 1997, it's been recognized that there are genetic markers of this, about 95% in JAGID1, Notch2, which is its receptor, in about 1%, and that leaves 4% where we still don't have a proper genetic marker. Each pedigree or family has its own mutation. This was initially said to be dominant with variable penetrance because of the variability between affected family members and the syndrome generally. However, information from a mouse model, and we could explore that, but I don't think I have time, requires one jagged and one notch abnormality to be similar in terms of the cardiac features, cholestasis features, growth, etc., to the human version. So I think it's better thought of as being haploinsufficiency. David Piccoli and his group from Cincinnati have reviewed the diagnostic criteria more recently as a result of genetics. And I don't want to go through this table item by item, but what in essence it says is that we start with the classical diagnosis at the top with the 3 features without a family history. But the more evidence you have in the family, the more likely it is to be Alagille syndrome with less clinical features. And with genetics as well, it becomes easier to make a diagnosis with any evidence whatsoever. And as I said before, I think if there are genetic markers of Alagille syndrome in an individual, and there's Alagille syndrome in the family, one must be highly suspicious that at some point one of the complications of Alagille syndrome may occur, and then it becomes apparent that this patient did have Alagille syndrome all along, even though they didn't have a liver disease necessarily. So just to talk a little about the jagged notch system, it's a very phylogenetically old system going right the way back to invertebrates. And in fact, it was demonstrated first in Drosophila, fruit flies. It has influence over embryological and developmental and mature cell signaling roles. It's in mammals, it contributes towards vascular development, appropriate vascular development, lymphatic development, GI tract development, including the pancreas, ear and hair follicle development. Even in adults, it controls bone marrow cell line development. And also, as I'm going to show you from some of our own work, it has an effect on T cell function and the immune system. And it's also been shown to contribute to liver repair and fibrosis, or the control of liver repair and fibrosis in liver disease. I thought I would touch on another piece of work we did. We studied the eye abnormalities of patients with Alagille syndrome and their families, because one father who appeared to have Alagille syndrome went blind with a pigmentary retinopathy. So we wanted to make sure there was no pigmentary retinopathy in our patient population. So we studied the eyes in some depth and including with optic ultrasound. And we showed that all of the patients with Alagille syndrome had optic nerve head drusen, which are small calcific bodies in the retina around the macula. And in those parents who seemed to have any feature at all of Alagille syndrome, they all had drusen in at least one eye. So this seems to be a fairly sensitive marker of Alagille syndrome, although not universally used. I remind you, though, that drusen is seen as a degenerative phenomenon in the elderly, so that it wouldn't apply in those circumstances. Butterfly vertebrae are often mentioned as a diagnostic feature, but a little bit unclear what they are. So I thought I would show this, and you can see in the red circle on the left-hand side the radiological feature, which does look like a butterfly. And on the right-hand side, you can see a vertebrate which has been found, I think historically, and identified as having a butterfly shape to illustrate what they probably look like as a piece of bone. And there are other radiological and skeletal features in ribs, shortening of the radius, shortening of the ulna, phalanges, and other skeletal abnormalities. The cholestasis is seen, at least in our context, in over 90%, but then maybe because we're a liver unit, we kind of select that group of patients. They're typically jaundice, have pruritus, and increased cholesterol with xanthometer. The nature of the cholestasis is a high gamma GT cholestasis. I've only ever seen one patient who didn't have high gamma GT cholestasis who turned out to have Alagille syndrome. They typically have fat-soluble vitamin deficiencies and hepatosplenomegaly. Now, the histology has an interlobular bile duct paucity. However, this is very variable. It's not clear whether it's developmental. In other words, it evolves with time in a case of Alagille syndrome, or whether it's always there. The original description by Alagille suggested that you should take multiple biopsies from right and left lobes to make the diagnosis histologically. I think that's not realistic. We can't do biopsies to that level of intensity and risk. And therefore, we find that about 30% of patients at each age don't have characteristic biopsies. And some early on seem to have bile duct proliferation and could even be mistaken for biliary atresia. So it's important to be very cautious about the diagnosis of Alagille syndrome early on. I'd like to touch on the nature of the renal disease, which I think is becoming more and more important for a number of reasons I'll touch on. Alagille syndrome was recognized from early on by Alagille to have renal dysplasia, renal cysts, horseshoe kidney, a transient azotemia, which is a phenomenon whereby younger children have a period of acute renal dysfunction which seems to resolve. Renal tubular acidosis, which is probably the most prevalent phenomenon and difficult to detect unless one screens regularly for serum or plasma bicarbonate. These patients need their bicarbonate kept up above 20, or else they tend to get a metabolic bone disease. The risk of nephropathies related to drugs, and particularly after liver transplant with immunosuppression, needs attention. Patients develop chronic renal failure, and they even present with chronic renal failure. And the characteristic, although not unique, histological feature is so-called mesangiolipidosis, which has bile acid deposits and lipid deposits in the kidney. About 40% of Alagille patients were described by Benita Kamath as having evidence of renal disease. But I think, in fact, it's probably more than that if one looks much more sensitively, because this was a retrospective review. I've characterized the renal abnormalities of Alagille syndrome and subdivided them according to this classification, and I hope it's helpful. So the first type of abnormality is malformations, and I've listed there some of them which I've touched on already. The second classification, or second type, of glomerulopathy and mesangiolipidosis with tubulopathy and renal tubular acidosis. The third are vascular abnormalities and their consequences, which are seen and compound the other renal diseases, such as renal artery stenosis, mid-aortic syndrome, and hypertension. And then, of course, as I mentioned before, adding drugs, and including immunosuppression on top of the pre-existing Alagille renal disease tends to make them progress more quickly, particularly with respect to glomerulopathy, tubulopathy, and hyperkalemia as a problem. And a new area which is becoming evident, a new phenomenon in Alagille syndrome, is lymphatic abnormalities, including lymphangiectasia. And we have a case at the moment that we are struggling a bit with, who, following cardiac surgery, developed a severe plastic bronchitis. And this patient coughs up casts. We've embolized the lymphatics in the chest on 2 occasions, and the patient's just about controlled at the moment. It also responds to steroids. But this is a phenomenon which can be overlooked if one does not know that lymphatic abnormalities are prevalent, rare, but more prevalent in the general population in Alagille syndrome. I want to touch on the cardiac disease because this is important in terms of managing the condition. Not least because the collaboration with cardiologists needs to be very functional, active throughout all this. So the majority, almost all patients with Alagille syndrome, at least if they've got any other symptoms, have a murmur. And 95% have significant cardiovascular lesions of one sort or another. Peripheral pulmonary stenosis is the commonest single lesion in about 3/4. But those who only have peripheral pulmonary stenosis tend to have it milder, and that's about a third. If there is an intracardiac lesion, it tends to be associated with worse peripheral pulmonary artery stenosis. You see about 10% have tetralogy of Fallot. Right-sided lesions are much more prevalent, much more likely than left-sided lesions, and left and right-sided lesions together are rare, but they do happen. They are encountered. Now, the reason I want to touch on this from the liver point of view is that it's really important in the context of liver transplantation. There is a phenomenon, and I've kind of summarized it here, called reperfusion. And the phenomenon is that at the point of transplantation, when a new liver is implanted, it contains effluent from its preservation, which has an effect on the whole body of the recipient, but it causes peripheral vasodilatation, dropping the blood pressure, and pulmonary vasoconstriction, which increases the resistance to the right side of the heart. And if there is significant pulmonary artery stenosis, then the right heart can go into failure, and a newly transplanted liver does not cope with the high pressures of right-sided cardiac failure and may fail in the first 48 hours. This phenomenon is associated with recipients having worse pre-existing liver disease, and also with grafts with more preservation injury. So if you put a very good graft into a very stable patient without severe consequences of liver disease, they tend to avoid it more often than the higher risk situations. And it correlates with post-operative renal dysfunction and a longer period on intensive care and increased mortality. So this is a particular problem for Alagille syndrome. In the past, we unfortunately lost 4 patients with Alagille syndrome with this phenomenon until we began to understand it. And there is a literature, including from Pittsburgh and elsewhere, of a high rate of liver transplant deaths in the early transplant experience related to Alagille syndrome. So we developed this dobutamine challenge with a cardiac catheter to measure the cardiac output and the pressures in patients who we were thinking of listing for Alagille syndrome. So the criteria we chose at that time was to increase the cardiac index, the cardiac output, by at least 50%, but the right ventricular pressure not to exceed 50% of systemic during the procedure. In other words, it looked like the patient would be readily able to cope with the rigors of the reperfusion phenomenon. And so this dobutamine challenge mimicked reperfusion to see that it would be safe at transplantation. We're now using a different MR video technique instead of cardiac catheter, but we're still measuring pressures and outputs. And since we've adopted this assessment method and implemented it, not transplanted patients who failed this test, we haven't had any post-transplant deaths in Alagille syndrome, and the results are now excellent. And in fact, here is some UNOS data from the US. Some international data actually of the indications for transplantation. And what you can see here is that pruritus, xanthomas, bone disease, and failure to thrive are much more common indications than things like end-stage liver disease and encephalopathy. And quality of life issues exceed end-stage liver disease indications by about 2 to 1 in the literature. And that would be our experience too, in fact, perhaps even more so. And that's important because if one is undertaking or recommending liver transplantation for a quality of life issue, then one has to accept that if you didn't do the transplant, the patient would continue to suffer, but they wouldn't die. Whereas if you're going to take on a patient with a high risk of death, you have to balance the fact that is the risk of death worth the benefit of improvement of quality of life, but not actually life-threatening at this moment. It's a difficult decision. This shows 1 and 5 year survival this is UNOS data from the US in Alagille patients versus biliary atresia patients. The first 2 lines across are adult information. The second 2 are pediatric patients, and the bottom 2 are adult biliary atresia patients. And you can see that the 5 year survival for Alagille patients is better for adults than children in the US, and biliary atresia patients are closer to the Alagille patients in children. So, but nevertheless, for all 3 criteria, the results are very good. The vascular lesions have become clearer over the last 10 to 15 years, and they take the form both of vascular malformations and aneurysms, and also the form of bleeding tendency. They have implications for stroke, with cerebrovascular malformations and aneurysms and spontaneous bleeding, as I said, aortic coarctation, renal artery stenosis, and aortic aneurysms in children and young people. Here is an illustration of moya vascular abnormality at risk of spontaneous bleeding. And spontaneous intracranial bleeding is estimated in about 4 to 12% of patients. The problem is that we don't have a screening strategy because the risk of bleeding is not immediately associated with finding vascular abnormalities. And spontaneous bleeding has no marker of its likelihood to happen. Spontaneous bleeding is also recognized in Alagille syndrome. As I said, spontaneous intracranial bleeding, it's a cause of about 25% of mortality in Alagille patients after the first year of life. It's uncertain why spontaneous bleeding occurs in Alagille syndrome. It may be related to abnormalities of the vascular endothelium or its development. There's an associated increased surgical risk of bleeding. Markers which have been shown to be associated with the risk of bleeding are jaundice and raised cholesterol, but not direct coagulation abnormalities. It can be mistaken for non-accidental injury or abuse, and we've been in this situation, trying to unpick whether an Alagille patient had been abused or not. And in the end, it's very difficult to say. And we gave the parents the benefit of the doubt, obviously, but with care and supervision. And as I mentioned before, the role and design of any sort of screening for risk of bleeding is currently unclear. Now, as I have already described, one of the major quality of life, in fact, probably the major quality of life issue for patients and families with Alagille syndrome is itch. And it has a major impact on the skin with damage to the skin, lichenification, blood on the patient, on the clothes, on the bed from scratching, difficulty in sleeping, staying asleep, falling asleep, mood changes, low self-esteem, inability to concentrate, and impacts on education, ability to learn. Itch is very difficult to manage. This is a short summary of those medicines which we use, and this is our published protocol for the management of Alagille itch. And here's the evidence, categories of evidence underneath, which is not that strong, but there is evidence. And the problem is that pruritus was controlled by medication in only about 40% of cases. So that leaves 60% of Alagille patients itching in an uncontrolled manner. Obviously, there's an opportunity there for better management. One of the proposed approaches has been external biliary diversion. This is from a German illustration. It's been done in Poland, it's been done in the US. And a loop of intestine of small bowel is attached between the gallbladder, externalized, and bile is drained into a stoma bag. Now, our experience with this has not been good. It does work on occasion, but also there are problems with, for example, if the bile flow is not enough, it doesn't clear the itch, but you can also get ascending cholangitis through the gallbladder and infect the liver, which actually makes the liver disease worse. Also, children who still itch tend to scratch the stoma bag so it comes away and leaks bile, or they wake up in the morning with a bed full of bile because it's fallen off. So it hasn't worked well for us, and so we tended to go onto transplantation more readily for quality of life issues related to itch. Latterly, there are a number of drugs which are being developed, and I've contributed to 2 of them. That's one of my interests stated on the first slide. And these are IBAT inhibitors. They inhibit the reuptake of bile acids in the terminal ileum and interrupt the intrahepatic recirculation of bile acids. And in doing so, they deplete the bile acid pool, reduce serum bile acids, and then indirectly reduce bile acids deposited in the skin and the nerve endings, which contribute to the itch. And they seem to work quite well in most patients, but not all. And I show you beneath 2 plates illustrating a study. On the left-hand side, sorry, just the nature of this study was that the patients were being treated with maralixibat, an IBAT inhibitor, and on the left-hand side, they were put onto, they were told that they were going to get a withdrawal, but they were, they didn't have a withdrawal, whereas on the left-hand plate, but on the right-hand plate, they were given placebo. And you can see on the left-hand side, there was really no change in the itch, whereas on the right-hand side, during the month that they were given placebo, the itch came back, and on reinstituting the medication, it improved again. In this same study, they showed over a 4-year period that, sorry, you can see perhaps, because it's not a linear scale, the red columns illustrate the period where patients had the medication withdrawn, but over a 4-year period, steadily, the control of the itch improved, probably as the total bile acid pool was slowly depleted. After initial big improvement, it steadily got better, and the itch got better. And simultaneously, over the last 2 years of the 4-year period, as the bile acids remained lower, the itch remained better, the patients showed some catch-up growth. I move on now to the idea of immunity in Alagille syndrome. We were suspicious that many of our patients were getting more infections than you would expect. So we looked back over a 2-year period in 2011, 2013 about the numbers of infections. And this is in patients from 6 months of age up to 57 years of age. We have some patients at that age we're following, median 19 years. And we defined the episodes of infection according to the horizontal line. And we encountered about 60% of patients having excessive infections during that time. So we went on to study 4 patients who we thought had many more infections than everyone else. And here's a summary of the 4 of them in the columns on the right, 4 columns on the right. And on the left were 2 control normal patients whose immune systems we simultaneously studied. And we looked at lymphocyte function in vivo and in vitro. And what we found is summarized here, that patients with Alagille syndrome seem to have lower interferon gamma responses, lower IL-10 responses, and higher, in some of them, IL-5 and IL-4 responses. And we interpreted this as showing that the Alagille patients tend to be pro-inflammatory. So it may well be that they don't get necessarily more infections. It's just that when they do, their inflammatory process is activated, but is not switched back off again. And so they go on showing symptoms for a more prolonged period. So, what is, sorry, what's the prognosis of the liver disease? Sorry, I've got about 20 to 40% of patients with Alagille syndrome will end up going through a liver transplant, either for life-threatening or quality of life issues, more of them quality of life related. 77% of patients are still jaundiced at 15 years, and 80% of them, which is a similar number, will have itched at one time or another or still do. 25% reach cirrhosis at 10 years of age. It's unpredictable what will happen in adulthood, but a proportion will decompensate and go on to transplantation at that time. There is an idea often put about that there's a spontaneous improvement in cholestasis, in itch and jaundice, in patients with Alagille syndrome, particularly about puberty. So 2 papers have considered that possibility, and it does appear that there is a spontaneous improvement of cholestasis in about 20% of patients, particularly around puberty. And liver malignancy is certainly described in Alagille syndrome. It's not clear if they're at a similar rate to other biliary diseases, which is something like 0.6% per year if they have cirrhosis. There's no reason to believe particularly that it's any higher, but HCC does turn up in Alagille patients sometimes. Other aspects of the total prognosis are related to spontaneous hemorrhage, and I've touched on that, which is in terms of mortality is 25% of the cause at this later age. The renal prognosis is important. Thyroid function I'm going to touch on in a moment. Question of bone health with pain and fractures, immune function and pro-inflammatory conditions, consequences of hyperlipidemia, and cardiovascular disease prognosis, particularly congenital heart disease, and what happens in the long term to those patients. Now, the prognosis of renal conditions is not entirely...
2 minutes. 2 minutes, please.
This is about right. The renal abnormalities, as I say, I've seen about 40, but that's 3/4 of screening patients. We don't know what the natural history of Alagille renal disease is, but if there are 4 etiological forms, as I described in my previous slide, then probably it's variable. Young adults occasionally present with end-stage renal disease, never having been known to have Alagille syndrome. And Alagille is a cause of renal failure presenting de novo. And of course, I mentioned immunosuppressive nephropathy. Can I mention the thyroid disease? Because it's becoming clear that thyroid disease is more frequent in patients with Alagille syndrome. This is a series of 6 patients with thyroid dysfunction with hypoplasia and ectopia, being 28% of a cohort. And I think Alagille syndrome may represent an increased risk of hypothyroidism throughout life. And there's a zebrafish, a jagged notch pathway model for development of hypothyroidism. Bone health is an issue. I'll just touch on it very quickly, but you could imagine as a result of vitamin D deficiency, renal disease, low bicarbonate, there is a need for long-term monitoring and bone densitometry of patients with Alagille syndrome. So in summary, Alagille is a rare and complex multi-system disease, and jagged notch interactions are more important throughout development, but also in various adult body functions than was appreciated in the past. I think we've resolved the transplant conundrum of quality of life versus life-threatening disease and how to improve the prognosis to as good as any other indication for transplantation. Itch remains problematic, but we have some new drugs. And the implications of Alagille syndrome tend to be pervasive and long-term and require knowledgeable follow-up. We're still discovering clinical aspects all the time, and by the implication of jagged notch interactions and their dysfunction. And I think that immune function may well prove to be very important. Thank you very much indeed.
Thank you very much, Dr. Baker, for this nice review. And I would like to apologize for questions because of time. I may ask you just to stay for another, no questions. Can we allow a question also? Okay, so just 2 short, quick questions, please. And ask people in the back who give a chance to people who never asked.
Thank you for this amazing talk.
Just raise your voice, please.
Thank you, Prof. Baker, for this amazing review. I have 2 questions. The first one, in case of severe hypercholesterolemia and disfiguring exanthoma, in post-liver transplantation protocol, would you continue on anti-hyperlipidemic medication?
Sorry, what you're asking, do you need, if they're on anti-hyperlipidemia medicines for xanthomas, you continue it after transplant?
Yes.
You don't need to. The xanthomas melt away. Sometimes you can even see them disappearing day by day. If the bile flow in the new liver is good, within about 2 or 3 weeks, what were hard cholesterol deposits become sort of baggy and loose as the cholesterol just leaches out of them.
Okay, thank you. Second question, you mentioned about the reperfusion phenomenon. So again, in your protocol, would you start the renal sparing agent from beginning, even if the urea and creatinine normal? Thank you so much.
Absolutely, yes. No, that's a great question. We have a renal sparing transplant regime which involves giving basiliximab at day 1 and day 4, and then putting on mycophenolate mofetil as soon as diet is established, and then running tacrolimus levels instead of 10 to 12, something closer to about 7 to 8, or even lower than that if the renal disease is more significant.
One more question.
Thank you very much, Professor Baker. I have one question. In babies who have complex heart disease and have a total bilirubin more than 300, we always have difficulty and debate between, the cardiac surgeons and as a hepatologist or transplant, which to fix first? Is it the heart or the liver?
There is one circumstance where that's very clear, and that's biliary atresia, not Alagille syndrome. And I think it's really important to fix the heart before you do the Kasai operation. Now, we're not here to talk about biliary atresia, but I make that point because it's so important. The danger is that well, first of all, it may be that if there's back pressure from the cardiac lesion, the liver will do worse anyway. But even if it doesn't, you can get into a situation where you've done a Kasai, you're waiting for 3 months to see if it works properly. And meanwhile, the cardiac lesion is not sorted out. And then the patient is cirrhotic, and you can't go to bypass surgery and fix the heart. And the patient needs a liver transplant, but the heart prohibits it, so the patient dies. It's really important to fix the heart first and then do a Kasai operation. In the context of Alagille syndrome, it's a bit more complicated because, as much as anything, because cirrhosis develops much more slowly in Alagille syndrome, and because the nature of the complex heart disease tends to be more difficult to fix because so many of them have peripheral pulmonary artery stenosis, which can be stented, but it can't be stented very easily in tiny babies. So I think the case I would make here for Alagille syndrome is close discussion with the cardiologists to decide when you have to have the heart ready for liver transplantation if it's necessary.
Okay. Thank you very much. I'd like just to ask you to stay for another, and thank you very much for Dr. Baker. Thank you for being with us today. Have a good day. Okay, let me ask you to just to stay and just for a few minutes, we'll have a honoring ceremony for the sponsoring companies. Okay, Dr. Ali, please.
Like really to thank the sponsoring companies. First one is the Nutrition Company. Please, can you come to take your gift? Thank you so much. Thank you so much. The second company is the Nestle company. Thank you so much. The third company is Abbott company. Thank you so much. الله يعطيكم العافية جميعا. So now there is a break time for 1 hour. We'll be back at 1:30 for home. اللي يبغى يصلي في المسجد يعني من أهل جدة، أقرب مسجد للجمعة اسمه مسجد مدينة الصين، لابد سيارة. في مصلى هنا للمسافرين اللي يبغى يجمع ويقصر. الله يعطيكم العافية. نبدأ 1:30 بإذن الله. العودة 1:30. هذا المطعم في
عشاء البارح.
نفس مكان عشاء البارح. Also, you can scan the code for your attendance. Only almost 50%. Excellent.